Well, ladies and gentlemen, we already had a very fruitful discussion during the past 3 days, and currently we enter the last day of this outstanding symposium. At this moment, we'll have a very nice session entitled The Recent Advances in Obesity from Pathophysiology to Management. We would like to send our gratitude to Novo Nordisk Indonesia who have been supported our symposium. As we all know, obesity is a complex chronic disorder that is related to several etiology and will affect several aspects in either physical, mental, and also social aspects of individuals. So for conducting optimal management, of course, it is mandatory for us to understand the comprehensive approach for obesity, starting from diagnosis to the optimal and comprehensive management, which is considered by non-pharmacological and also pharmacological approach. Well, to deepen our understanding about this topic, currently we already have our distinguished speaker. He is Dr. Farid Kurniawan. Let me invite Dr. Farid to the stage. Hello, Dr. Farid.
Hello, Dr. Wafa.
How are you, Doc? Good afternoon. You already good morning, right?
Yes, it's still morning here in the Netherlands.
Morning there. Well, long time no see you, Dr. Farid. Okay.
Yeah.
Yeah. Well, I will firstly read curriculum vitae of Dr. Farid. Dr. Farid Kurniawan from Metabolic, Cardiovascular, and Aging Cluster of Indonesian Medical Education and Research Institute. He finished medical doctor from Universitas Indonesia and also followed by internists from Universitas Indonesia. And currently, Dr. Farid doing the PhD candidate he's the PhD candidate in Leiden University. Currently, he is a junior investigator from Metabolic, Vascular, and Aging Cluster, IMERI. He also staff lecturer in divisions of endocrinology, metabolism, and diabetes, Department of Internal Medicine, FMUI RSCM. He also vice chair of MVA IMERI, and also a member of Indonesian Society of Internal Medicine, and also a member of Indonesian Society of Endocrinology. Well, Dr. Farid, without further ado, I will offer the stage to you. Time is yours.
Yeah, thank you, Dr. Wafa, for the very kind introduction. Good afternoon, dear attendees of first CMARS Symposium, and good morning also all of the participants from the Netherlands, and also good afternoon, I think, also in Japan. Today, I would like to share a bit about what already mentioned by Dr. Wafa regarding the advances in the obesity management. I would like to thank to the committee for the opportunity. I'm trying to share my screen. Did you see my screen?
Yes.
And I will change it to the slide view. Is it correct, one?
Is it clear, Dr. Farid?
Yeah, okay. So I changed, I'm sorry, I changed a little bit of my title, the recent advances, the committee giving me the recent advances in the obesity from pathophysiology and management. I changed it a bit because of the limited amount of time, and also yesterday, Dr. Diki already mentioned a lot regarding the pathophysiology of obesity. So I decided that today I will focus more on the obesity management. This is my disclosures for this symposium. As we all know that obesity is a global health challenge currently. We'll see from the last decade, the prevalence of obesity is increasing. And if we look at 2030, it's predicted that 1 out of 5 women will have obesity and 1 out of 7 men will be living with obesity. So it's really a global pandemic for this obesity condition, as well as with the other non-cardiovascular, non-communicable diseases like obesity, like diabetes or cardiovascular diseases. Similar condition actually also observed in Indonesia. If we look at the report of the Indonesian Basic Health Survey from 2007 and 2018, it's already doubled up of the prevalence of obesity based on the BMI or also based on the waist circumference. Unfortunately, regarding the country preparedness, our country is in Indonesia is actually, we can say it's a lot below compared to the other Asian country here, especially in the Southeast Asia. And what is the reason for this really unpreparedness of this obesity management? So one of the reasons, and it's not only in Indonesia, but also happen in many countries, because obesity is not commonly acknowledged as a complex or chronic diseases. Most often is only considered as an aesthetic problem. And if we look at this research, from 100% that people actually with obesity based on their BMI, it's only half of it that being diagnosed with obesity by the healthcare professional, and even worse, only half of this 50% only will be scheduled for a follow-up care later on. So as already mentioned by Dr. Dicky yesterday, it's important to acknowledge this obesity as a chronic disease. So there is a new term for obesity. It's called adiposity-based chronic disease, and it will later evolve into dysglycemia-based chronic disease, cardiometabolic chronic disease. So we have to really change our paradigm and consider obesity as a complex and chronic disease. Why it is complex and chronic disease? Because we can see here in the slide that obesity is really associated with multiple complications such as metabolic complication here, diabetes, cardiovascular diseases, even cancer. And not to forget about the mechanical complications regarding GERD, asthma, and also muscle and joint pain. And lastly, but very important also, is the mental problem related with obesity, with discrimination, bullying, depression, and also anxiety. More to add those complexity is this a way on how to tackle obesity. A lot of aspects involved in tackles obesity, not only regarding its patient itself, but also involve the society, the environment, and also even the government. Speaking of obesity, as already mentioned by Dr. Dicky yesterday, we have to talk regarding the energy balance or energy homeostasis. It's the balance between the energy intake and energy expenditure. And this balance of this energy intake and energy expenditure is really complexly regulated, especially by human brain. And it's also involved a lot of organ in our body, including adipose tissue, pancreas, and gut, with its hormone signaling, and also the gut microbiome. Not to forget the importance also genetics that I will gonna discuss a bit later on, and also regarding the medications. And to make it more complex about this energy homeostasis, there is also role of environment regarding the lifestyle, smoking, psychosocials, and also the hedonic input, the pleasure of having food and also other drinks. And speaking of the energy intake, we cannot escape from what we call about the eating. And eating is also related with the appetite, with feeling hunger and feeling satiety. And a lot of peptides are involved in these regulations of hunger and satiety feeling that regulate the neurons in the hypothalamus in the brain. And it's also correlated with or associated with other organs in the body that's rather associated with the system of feeding, gastric emptying, and also the metabolic rate. Ladies and gentlemen, all attendees of first CMARS, after discussing about the complexity of the obesity itself, now we come to the how to diagnose obesity, like Dr. Wafa already said. The easiest way or the most convenient way to diagnose obesity is using body mass index, a function of body weight and height. And WHO already recommend for like Caucasian populations, it's used cutoff of 30 for the obese BMI. And for the Asia Pacific, WHO recommend the cutoff of 25. In Indonesia, for the latest report of the Indonesian Basic Health Survey, it's still using 27 kilogram per meter square. But our latest recommendation here from the Indonesian Society Indonesian Association of the Study of Obesity, we recommend the use of BMI cutoff of 25 for this obesity diagnosis. Why? Because many studies have been performed in Indonesia regarding this obesity, showing that if we use cutoff 27 compared to the 25, many patients will be mislabeled as not having obesity, but actually most of those patients already experience obesity-related complications. That's why we suggest to use this cutoff of 25. And in this recommendation, also, we emphasize to acknowledge obesity as a chronic disease for all of the healthcare professionals, and also the emphasis of using a staging system for obesity, like Dr. Didi already mentioned yesterday, as an Edmonton obesity staging system. Here, we don't stop after we diagnosed obesity using the BMI, but we also find all of the complications and then put it in the staging system of the Edmonton obesity staging system. One problem with using BMI for diagnosis of the obesity is it's not always represent of overall body fat mass, and it's all not always represent the cardiometabolic risk of the obesity itself. So one index that can help with the evaluating this cardiometabolic risk of obesity is waist circumference. One example why BMI is not a really good index is like for an athlete, they can have really high BMI, but they might have lower body fat mass. And another example is regarding diabetes. Compared to Caucasian population, Asian population with the same level of BMI have higher risk of diabetes. So recommendations also use this waist circumference as a index for measuring obesity, especially we call it abdominal or central obesity. This is how we measure it. There are several ways, according to WHO or according to NIH, and the cutoff for Asian population mostly being used is 90 centimeters for male and 80 centimeters for female, although several countries in Asia using other cutoff. And we next proceed to the how to do the effective weight management in this obesity. So what is the first goals of this obesity management? First, surely we want to achieve as much as the weight reduction until approaching the normal level. Usually it's really hard to obtain those normal BMI. Usually we come with the 5 to 10% compared to the baseline, and that's already a significant decrease. And the next one is how to maintain those weight loss and prevent the patients to gain their weight again in the long term. So most of the patients will have problem to maintain their weight loss. And the last one is how this decrease in the body weight will have a clinically meaningful benefits in the long term, such as reduce in the diabetes risk and also cardiovascular risk, and also improve the functional impairment and the quality of life. Now, I would like to talk regarding the set point theory. So I already told you about the energy homeostasis, and regarding the obesity, with the continuous positive energy intake, there will be a sustained positive energy balance, and this sustained positive energy balance will resetting the body weight set point into a higher value. So if you increase your energy intake, the set point will be increase and increase. And the goals with the weight management is how to decrease again or reduction in the set point to the normal level or as normal as possible. Unfortunately, a lot of factors influence this body weight set point, like the biological factors, genes, environment, and also behavior. And this become the most challenging in the weight reductions in the obesity management. There are one systematic review show that several studies, if we look at the slide here, most of the studies show that after significant reduction in the body weight, after long term, most of the subjects will come again to the baseline body weight, even around, I think 40% will go past beyond the baseline body weight. So it's really challenging for this weight loss maintenance. What are the reasons for this problem with maintaining of the body weight? Sorry, yes? Okay, so the reason of the weight difficulty of the weight loss is the increase of hunger and desire to eat after you try to lose your weight. Even after long term, even this desire to eat or hunger become higher compared to the baseline itself. To make it even worse, there is a problem regarding this metabolic rate. So this related with energy expenditure. If you perform a very low calorie diet or intervention here, only until week 30, it's already decreasing in the metabolic rate. But if we look at the 6 years after the intervention, even the resting metabolic rate even become lower. So it makes the things even worse. So if we try to decrease the energy intake by decreasing the calories intake from food or drinks and increasing the physical activity or exercise, our body will adapt to the opposite directions by decreasing the metabolic rate and increasing the hunger hormone and decreasing the fullness hormone. So it's like a tug of war in the weight management. Ladies and gentlemen, now we come to the point of this advance in the management of obesity. Last year, several experts in the obesity field come up with a consensus regarding the treatment of obesity in South and South Asia, and they focus and emphasize of the personalized approach regarding the drivers, barriers, and impact of the excess weight in this obesity. And they also emphasize the evaluations after diagnosing of obesity-related complications, and the use later on with obesity, Edmonton obesity staging system. And they also recommended the weight loss of 5 to 15% over 6 months, and it has to be tailored therapy with assessed periodically for each patient. It's a step up management using diet modification, physical activity, behavioral therapy, and later on, if it's not succeed, step up into pharmacological management and also surgery. This is what I call a step up, and also it's regarding the multidisciplinary approach for this obesity treatment. All of these healthcare practitioners will involve in one stage of the obesity treatment in each patient. So if we look at this figures, behavioral modification and lifestyle interventions is always included in all of patients with undergoing obesity management, and later on for patients with BMI above 30, pharmacotherapy directly recommended, although it can also use in the BMI of 27 with obesity related complication. Meanwhile, for surgery, usually it's above 35 or above 40. Later, I will come to this. First, we talk about the modality of dietary interventions. The easiest way to reduce the intake of calories is by energy intake is by reducing the calories intake. It will cause the negative energy balance in our body, and by decreasing around 500 to 1,000 kilocalories per day, usually it will resulting in a loss of 1.5 or 1 kilogram per week of body weight, although it can differ in each patient. And I suggest, and a lot of studies suggest that for dietary intervention, you consult with the medical nutrition specialist or dietitian or nutritionist. There are a lot of types of dietary interventions. We can see here a lot of debates, which one is better, whether it's low fat versus low carbohydrate diet, whether it's a low calorie versus very low calorie diet, and some of regarding time-based energy restrictions. Now you heard quite often regarding this intermittent fasting, and a lot of other diets that are already well known, like Mediterranean, Atkins, vegetarian, ketogenic. I will not go into detail for each of these types, but important to note that there is no one diet that can suitable for all of these obese patients. It has to be evaluated by either their physician, dietitian, or medical nutrition specialist. What are the best approach for each patient? One of the advances in the obesity management regarding these dietary intakes is the use of genetic approach, nutrigenetics and nutrigenomics. Nutrigenetics is how your genes affect your body when you intake food, and the opposite is the nutrigenomic, what you intake, and then you will involve or affect your genes behave. And many studies have shown that with the approach of this nutrigenetic and nutrigenomics and even nutriepigenetic, it will improve the weight loss and also improve the reduction in the cardiometabolic decreasing of the cardiometabolic risk for this obesity. One example is, if we look at this FGF21 C allele polymorphism, if you have this C allele, if you look here, then you will have a greater reductions of the waist circumference, total fat mass, and also trunk fat if this patient given a low-calorie diet with consists of high carbohydrate and low-fat diet. And the opposite if you given them the low carbohydrate and high fat diet. So it's really most of the people would some would recommend low carbohydrate, low fat diet or high fat diet, but for these type of patients that have this polymorphism, it will beneficial for this approach of dietary intervention. Next modality is the physical activity and exercise. The fact is actually it's really easy to reduce the energy balance by reducing the intake of calories compared to the burn of the same amount using exercise. As an example, if you want to reduce 100 to 150 kilocalories from your energy intake, it will be really easy to reduce it from the food compared to you burn it from the exercise. It will around 45 to 60 minutes of jogging or walking to get the amount, the same amount of reduction in the calories. But many studies show that this physical activity and exercise is really important for maintaining weight loss. As you can see here, after 18 months, the subjects that have weight loss more than 10%, they also have higher amount of moderate vigorous physical activity and also light physical activity. You can incorporate all of these physical activity in regular routines, or you have an exercise, either aerobic or resistance training. And other than that, other than the body weight loss, there are also a lot of beneficial effect of this physical activity and weight loss. And regarding the advance in the physical activity and also regarding the dietary intervention is about the using of E and M health, like this digital weighing scales, physical activity tracker, and calories intake app. Systematic reviews and meta-analysis have shown that the use of this technology can really improve the weight loss outcomes for the obesity management. The next modality is regarding the pharmacotherapy. If we look at these figures, to get the drugs that really can reduce the body weight is a long and complicated road. From 1933 to now 2023 is around like 50 years. There are already a lot of drugs that being approved for obesity management, but a lot of them also have been retracted from the market. Fortunately, in the last decade, there are already several obesity drugs that give promise, like quite promising in this term of efficacy and safety for this obesity management. Most of the time, these drugs are retracted from the market due to the safety regarding the cardiovascular effect and also in the mental effect like depression and suicidal. So I already talked to you regarding the lifestyle modifications, and actually the lifestyle modifications is the maximum body weight loss that can achieve is around 8%. And if we compare it to the surgery, it's range from 16 to 32%. So there is a gap between this 8 to 60% that come or hopefully will be filled by the pharmacotherapy plus lifestyle modification. These are several pharmacological options that are available in the market. In Indonesia, we have only STAT. We don't have the naltrexone bupropion, but we do have the ethylpropion that also work as an appetite suppressants. We don't have phentermine and topiramate. I think the closest is Singapore that have it. In Indonesia, we don't have this liraglutide 3 mg and semaglutide 2.4 mg. We do have the liraglutide 1.8 and semaglutide 0.5 and 1.0, but that's being used for type 2 diabetes. So it will be an off-label use if we use that preparations in Indonesia. So I will discuss regarding several drugs that really promising as an obesity treatment. First is the semaglutide 2.4 mg. It's a GLP-1 receptor agonist. The mechanism action is by decreasing the appetite and also slower the gastric emptying and also improve the metabolism of glucose and lipid. These drugs given once weekly by subcutaneous injections, and the latest phase 3 clinical trials showed that these drugs can resulted in the reduction approximately 50% compared to the baseline after treatment of 68 weeks. The next drug is quite potential regarding the tirzepatide. It's a GLP-1 and also GIP receptor agonist. Its mechanism action is similar like the semaglutide that I've mentioned before. It's also given once weekly with subcutaneous injections, and the highest dose in this phase 3 clinical trial, 15 mg, resulted in approximately 20% reductions in the body weight. And the last drug that I would like to show you here is called bimagrumab. It's a monoclonal antibody that works as the inhibitor of this activin type 2 receptor. This activin type 2 receptor pathway, it actually works in the blockade of the skeletal muscle growth. And by giving bimagrumab, then you have a hyper expression of this skeletal muscle growth. And latest phase 2A trials given bimagrumab 10 milligram per kilogram intravenously with 4 weekly interval in 12 dose and given in this subject, it resulted in the decrease of body fat mass around 20.5%. And interestingly, it also increased the lean mass about 3.6 to 4%. So another advantage of this drug is not only decrease the body fat mass, but also increase the muscle mass. But we still need more research regarding this drug to see further the efficacy and also the safety. I think the phase 2B trials in now is still ongoing. So if we look at these 3 drugs, semaglutide, tirzepatide, and also bimagrumab, it's really promising because they really can fill the gap that I already mentioned for those 8 to 16%, even more. They can reach up to reduction of 20%, closing to approach of the bariatric surgery. So the last modality is the bariatric surgery itself. It can have several techniques like gastric banding, sleeve gastrectomy, and also gastric bypass. And it's recommended in, I already mentioned, in the BMI more than 40 kilogram per meter square for Asian populations more than equal 35. These are the patients that we call morbid obesity or severe obesity. It's also recommended in the patients with the BMI more than 35 with comorbidities of obesity such as type 2 diabetes, hypertension, obstructive sleep apnea, and even can be considered in BMI less than 35. It's already failing a lot with the lifestyle intervention and also pharmacotherapy. This bariatric surgery can result in the significant and also sustained weight loss in the long term. Although most people might opt this surgery as the last frontier, but it's indeed really beneficial for the management of obesity. So I come after discussing all of the advances in the obesity management, I would like also to discuss regarding the barriers of obesity treatment in Indonesia. So it's not only from the patient itself, like the unrealistic goals. They want to reduce the body weight in a lot of numbers in the really short amount of time, but also regarding the poor adherence and the consideration is of obesity just as an aesthetic issue, not as a chronic disease. But also the barriers from the society and the environment, and also from the government, like the lack of political will, interest, and actions, lack of the financial investments, and also the poor availability of the pharmacotherapy options in the market. So to summarize what I already discussed before, I would like to emphasize again, obesity is a complex and chronic disease, but definitely it's a treatable disease. And management of obesity is not only decreasing the intake of food or drinks, and also increasing the physical activity and exercise, but obesity treatment is a very complex and using a step-up approach and personalized approach with multiple modalities and multidisciplinary. Luckily, several new modalities have been developed in the last decade for this obesity treatment and currently being implemented, although more research are needed to really know this efficacy and safety of this new modality. Last, I would like to emphasize that this obesity treatment has to be our next pandemic priority. Thank you for your attention. I would like to discuss more further of this hot topic with all of you. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Well, thank you, Dr. Farid, for a very insightful presentations. I think we have learned so many lessons from your talk. And we have, I think, 15 minutes for a Q&A session. We already have 2 questions. The first is from Dr. Ervi Praviantini. She sent privately message to me, Dr. Farid.
Yes.
Yeah. Dr. Ervi asked about the importance for knowing the body compositions in our patients rather than the body weight, only to reduce the cardiometabolic risk factors.
Yes, thank you for the great questions, Dr. Ervi. Yeah, I agree. I didn't mention regarding the body composition in my presentation because of time. So I really agree with you that the body composition is also important in this obesity management, because sometimes, even not sometimes, most of the time, the BMI and also the waist circumference cannot really represent the exact body fat mass in the body, like the composition, because we have the visceral fat and we also have this subcutaneous fat. It's really interesting if we I think a lot of practices use this body composition, and for the management itself, if you lose your body weight, you have to really see whether the body fat mass is decreasing or your lean mass or your muscle mass. The target is that the body fat mass is that the one that decrease, not the muscle mass. So I would suggest, if we can have those body composition, it would be really, really great to include that in the management of these obesity patients. Then you can see if they decrease most of the time is the muscle mass, then you don't want that. But if you have a significant decrease in the body fat mass, then you go into the right directions. That's my comment on the using of the body composition.
Yeah, so the body composition measurement will be our next anthropometric importance measurement, Dr. Farid. And maybe we should do this that measurement routinely in our daily practice, Dr. Farid. What's your opinion about that?
For the diagnosis itself, it's not it's important, but not necessarily. But for the management itself, I would agree. If we have these tools or equipment for the daily practice, it will be very beneficial, because if you have muscle mass that maintain, then it will also help with the metabolic rate itself.
Yeah. So that's the importance point. Okay, thank you. Okay. Thank you, Dr. Farid, for clear answers. So we go forward to Dr. Eva Indrasari. Dr. Eva asked about the methods for the effective methods to prevent weight regain. You have talked about this after years of weight loss. Based on her experience, many patients experiencing significant weight regain after 25 years after losing weight, even though they are still exercising. And most of them complaints of their appetite seems to be higher after years of losing weight. It's very interesting. Yeah.
So your everyday clinical practice already proved what I already mentioned in my presentations, that the hunger itself and also the desire to eat, the appetite is even increased after losing weight. So indeed, already being proven here. For the effective management or effective methods to prevent weight regain. Unfortunately, I cannot really answer that precisely because there are no no exact way on how this being prevented. Like, I think pharmacological treatment could help in this decreasing appetite, like the one that I showed you before, the semaglutide, and also the tirzepatide and several other like diethylpropapion. That might help, but I think regarding the obesity itself is a long-term management. You have to evaluate again, even though their appetite is increasing, but they really have to consider how to still manage their food intake. Like the energy intake also have to be maintained, because if they increase their food intake, then the body adaptation will absorb all of those calories as much as possible as the adaptation from the previous body weight loss. So if they can maintain body weight reduction in the long term, and they can decrease the body set point to the levels lower than the previous one, like the level already higher because of the positive energy balance before, and then they become lower again at the body set point, then they can maintain the body weight regain. As a people that experienced obesity myself before, it's a struggle indeed. It's a long life. I think it's a long life management. The best way is not to be obese, to prevent the obesity itself. But if you're already obese, I think you cannot really depend on 1 year or 2 year treatment, but it's a really long life management.
Okay. Because it deals with the reduction of set point, right, Dr. Farid? Not only.
Yes, we never know when the set point is already achieved. But if you already significantly reduce the body weight set point, you can see that although you increase your food intake, it's not really increasing your body weight. And after you decrease a little bit of your intake again, then it already decreased your body weight. But if you increase a little bit and then of your intake, then you have a higher increase of your body weight, then your body weight set point is not significantly lower.
Reduced. Okay.
Reduced. Yeah.
Notice, Dr. Farid. Thank you. Very clear. So I've seen Prof. Pradana raise hand, but sorry for Prof. There's still one question from Dr. Eva. Dr. Eva asked for her second question. Is it recommended to give early start, Dr. Farid, and acarbose combination to help obese patients in weight loss program?
I haven't. I don't know about any study whether regarding the early start and acarbose, but in my personal opinion, you don't want to give these two medications together because they perform the similar way of mechanism, so it will not really add up or go synergistically, but you will have more side effects. That's my personal opinion. So if we want, you would like to combine orlistat with maybe appetite suppressants like diethylpropapion, and maybe if we later on have the preparation of semaglutide 2.4, then you might also want to combine that. That's my answer.
Thank you, Dr. Farid. Maybe we proceed to the next questions from Prof. Pradana. Prof. Pradana, will you ask live? Yeah, please, Prof. Pradana.
Yes, thank you, Dr. Wafa, for the opportunity, and thank you, Dr. Farid, for your nice presentation. I'm interested on bariatric surgery. First, is there a study that mentioned that actually bariatric surgery can expand the lifetime? Yeah. And
like
then the second
life
expectation, maybe, Prof. Yeah.
And then the second one, in the past there is bariatric endocrine So it's like that put something in by endoscopic, something like that. But you don't mention about that. It is still available in the international practice, or it's already sudah ditinggalkan. Yeah. Okay. Maybe it's the two questions. Thank you. Thank you for your.
Thank you, Prof. Pradana. Please, Dr. Farid.
Thank you, Professor Pradana, for very nice questions. The first one regarding the life expectancy after bariatric surgery. To be honest, I haven't read about that, but in theory, I would agree if you have severe or morbid obesity before, and then you underwent a bariatric surgery and experienced significant weight loss or weight reductions, I would expect the cardiometabolic risk of this severe or morbid obesity will decrease significantly. So hopefully by decreasing significantly this body weight, then you don't have the cardiometabolic risk, and then you would expect to have more life expectancy. That's my answer for the first questions. And the next question regarding the bariatric endoscopy, yes, they're still available. I didn't mention that in the slide presentation. Actually, yes, there are several tools or modality for this bariatric endoscopy that even already being approved by FDA in the United States, and it's quite promising. So it's a like minimally invasive for the patients, and it can reduce in the body weight, like reduction in the body weight. So it's one of the advances of modality in the obesity management that now being used.
Thank you. Thank you very much.
Thank you, Dr. Farid. Thank you, Prof. Pradana. Actually, our time is over, but I think there's one very important questions from Dr. Ervi, actually about the indication of pharmacological treatment, Dr. Farid. In your slide, you write down that the indication for giving pharmacological therapy start from BMI over than 27 with complication. But actually in Indonesia, we use BMI more than 25 to classify as an obese, our proposed cutoff, Dr. Farid. So should we use this category as a cutoff to use anti-obesity or pharmacotherapy? Start pharmacotherapy, should we start at 25, BMI 25 or 27? That's the question.
Yeah. I think as a step-up management for the, as already recommended in the consensus from the Southeast Asia, and then hopefully in this year, the Indonesian Society, like Indonesian Association for the Study of Obesity, will also come up with another recommendation from Indonesian populations. So I would suggest to start still with the step-up management using this lifestyle modification first, with dietary interventions and also physical activity intervention and exercise before using the pharmacotherapy, because like the cutoff is 25, then with 20, especially if you don't have any comorbidities, then start with those lifestyle intervention. But if after 6 months there is no improvement, then we can consider to use the pharmacological approach.
Okay,
that's my answers.
Thank you very much. Thank you very much, Dr. Farid, for your clear answer. I think we come to our end of this session. For any conclusion that our obesity is the next pandemic, next pandemic and our problems. So we have to be collaborate, and we have to do the collaborations to do the comprehensive management of obesity to increase our quality of life of the population. Thank you, Dr. Farid, for this session.
Thank you,
and I
Dr.
think,
Wafa.
Yeah, I think we have to offer this session to the MC.
All right, thank you very much, Dr. Farid and Dr. Wafa, for the amazing discussion and presentation related to advances obesity. So we would also like to express our gratitude to Novo Nordisk as the sponsor for this session.
You know me. I am your mother, your sister, your wife, your friend. I am one of 650 million people. Throughout my life, I've lost weight, but have regained it time and time again. I've spent most of my life on countless diets. I eat my fruit, vegetables, and have made healthy choices. I've overcome judgmental stares and comments. But they don't know that each day I have to ignore my own biology, which controls my hunger. I've had my ups, my downs, my good days, my hard weeks, and my bad months. I've missed out on dream jobs and have been picked last in countless games. I've worked out over 200 days a year, year after year. I've even rowed halfway across the Atlantic Ocean, yet my body and metabolism work against me as I struggle to keep the weight off. I've taken responsibility. I've followed guidance and tried everything when it comes to my weight. And I'm still living with obesity.
All right, once again, thank you very much to Novo Nordisk as the sponsor for this session. Now we will begin Symposium 7 with the theme atherosclerotic cardiovascular disease. The session will be directed by Dr. Trijuli Aditarigan as moderator for this session. First of all, I would like to read the CV for Dr. Trijuli. Dr. Trijuli Aditarigan is from Metabolic, Cardiovascular, and Aging Cluster, Indonesian Medical Education and Research Institute. Finished medical doctor at University of Indonesia in 1997, and then undergo internal medicine in University of Indonesia in 2014. He also became endocrinologist, metabolism, and diabetes consultant at University of Indonesia in 2014, and then got his PhD at University of Indonesia in 2019. Currently, he is Senior Investigator, Metabolic, Vascular, and Aging Cluster, Indonesian Medical Education and Research Institute, IMERI. He is also head of the Division of Endocrinology, Metabolism, and Diabetes, Department of Internal Medicine, Faculty of Medicine, University of Indonesia, Cipto Mangunkusumo National Referral Hospital. So, without further ado, we would like to offer the time to Dr. Trijuli. Good afternoon, Dr. Trijuli.
Hi, how are you, Mutiara?
Fine,
It's
Doctor.
okay? Okay.
Yes. Right. So I would like to offer the time to you, Dr. Trijuli.
Sure. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good evening, dear professor, colleague, and ladies and gentlemen. So first of all, of course, many thanks for the committee for inviting us for this prestigious symposium. This session 7 of this symposium will title about the atherosclerotic cardiovascular disease. I think everybody in this room know that the atherosclerotic cardiovascular disease is one of the catastrophic disease in the world, and also in Indonesia. Of course, many risk factors for that. One of them is diabetes, high blood pressure, dyslipidemia, and so on, of course. And in this session, we will have two distinguished speakers. The one is Dr. Bambang Diputro from the National Heart and Cardiac Hospital in Jakarta, I think. And the second symposium will be Professor Muhammad Saiful from the University of Brawijaya, Malang. So we are lucky in this afternoon in our holiday. Yeah, we have the opportunity to discuss with these experts in cardiology and of all atherosclerotic cardiovascular disease. For the first session, I invite Dr. Bambang. Dr. Bambang will share with us about the about the atherosclerotic cardiovascular also. Uncover the burden of atherosclerotic cardiovascular disease. Can we reach the goals? And after this, I think since Dr. Bambang will left from our meeting, and I think after Dr. Bambang speaking, we will directly to discuss with the audience. Please, Dr. Bambang, time is yours.
Thank you, Dr. Trijuli, for the nice introductions and all the participants of CMARS symposiums this afternoon. Very good afternoon for everyone. Let me share my screen first. Well, ladies and gentlemen, now we will discuss about the uncovered burdens of SCVD. Can we reach the goals? This is my topic for this afternoon, and I'll start with the outline. The first one, we will discuss about what is the burden of SCVD itself, and the second one, what is the clinical benefit of lowering the LDL cholesterol, and what are the unmet treatment needs, and how can we reach the goals of LDL cholesterol. I will start my presentations with last year publications from the American College of Cardiology that published about cardiovascular disease projections in the United States based on the 2020 census estimates. If we look at in the summary of these publications, we got the projections of future cardiovascular risk factors and cardiovascular disease in the United States from 2025 to 2060. If we look at here in the diagram, the cardiovascular risk factors, including diabetes, hypertension, dyslipidemia, and obesity will increase around 20 to 40% in 2060. And therefore, the cardiovascular diseases such as ischemic heart disease, heart failure, myocardial infarctions, and strokes can increase around 35 to 40% in 2060. As well, and both women and men and women will largely remain stable over time in this increase. And this is the data from the EuroAspire 5 registry that recruited around over 800 of post-ACS patients from 27 countries. If we look at here, there is a huge homework for us to control the cardiovascular risk factors, including in the patients post-acute coronary syndromes. So we talk about the secondary preventions here. In fact, 20% of our patients were still smoking, and 40% were obese, and 66% had a physical inactivity. And look at this, 71% patients failed to reach the optimal cholesterol target. We admit together that the cardiovascular disease is the leading cause of mortality in the world, together with cancer, respiratory disease, and diabetes. And 80% of cardiovascular deaths are due to the heart attack and stroke. And WHO 2525 Global Action Plan was launched in 2013 to decrease the non-communicable related premature death by 25% by 2025. And if we talk about the elevated LDL cholesterols that lead the development of SCVD, so we're starting from the focal lipoprotein accumulations in the artery and the progressions of atherosclerotic plaque until the rupture plaque with the thrombus that results in myocardial infarctions or ischemic stroke. So it's a very long process. And there is precise linear associations between LDL cholesterol levels and the reductions in risk of coronary heart disease that's seen in the primary and the secondary preventions. If we look at into this graph, there is a consistent, the lower LDL that we achieve in terms of a primary and secondary preventions. So the lower the coronary heart disease fatal events that we got. There are several big trial here, and the results are consistent. And it is revealed that every 1 millimole per liter reductions in LDL cholesterol is associated with around 20% reductions of cardiovascular events. Many meta-analyses from different trials, including the statin therapy and the statin therapy with ezetimibe and the PCSK9 inhibitor, has gained consistent results that the reductions from major cardiovascular events and coronary heart disease mortality and all-cause mortality. And if you look at into the guidelines, we have two major guidelines from the ACC in 2018 and from the ESC in the 2019. We got the primary prevention treatment goals from the LDL reductions by 30% to 50% in patients 40 to 75 years of age with intermediate risk for ISCVD, and the LDL reductions more than 50% for those at high risk for ISCVD in terms of primary preventions. It will be slightly different in the secondary prevention treatment goals. We see here the American guidelines shows to us that the very high risk patients, including the ISCVD patients, should reach the target of LDL cholesterol below 70 milligram per deciliter. And there is an urgent need to use the high intensity or maximal statin in class 1 in the very high risk ISCVD patients. And it can be combined with the ezetimibes and the PCSK9 inhibitor if needed. And from the ESC guidelines, we got the conclusions in 2019 that we should stratify first our patients, whether our patients comes into the low, moderate, high, or very high risk category based on the risk scores, coronary scores, the cardiovascular risk factors such as diabetes and familial hypercholesterolemia, and whether there is a CKD or not, or diabetes mellitus durations. And once the patients get the ISCVD, it means that the patients will come into the very high risk category that should be lower, more than 50% reductions from the baselines or lower from 55 milligram per deciliter. That's the ESC guidelines show to us. And how about the LDL cholesterol goals attainment in Indonesia? There are several data. This is the data that quite long time ago, around 2013, that only 31% of our patients in Indonesia that reached the LDL cholesterol goals. And if we compare in the patients in Asia, it's only around 49%. So higher proportions of Indonesian hypercholesterolemic patients on lipid-lowering drug are not there at their recommended LDL cholesterol levels and remain at risk for cardiovascular disease. And this is one journal from European Heart Journal that showed to us about the LDL cholesterol attainment from the latest target below 55 milligram per deciliter. In fact, from 18 countries in Europe, Middle East, South and East Asia, and with a total of over 7,000 patients that enrolled this trial, it's only 12% of patients that reach an LDL cholesterol target below 55 milligram per deciliter. If we put in the high dose statin in combination with ezetimibe, the number will be higher, around 64%, so that will reach the target. If we put the PCSK9 inhibitor will be used in the remaining patients, the 94% will match the goal. So it's very important to know what medications that we use and the combinations that we use and the potential target therapy for to lower the LDL cholesterol level. This is our local data. We did a multi-center INTERSPIRE study that recruited from 7 centers in Indonesia. We recruited 400 subjects from 7 centers. all of the subject is post-cardiac events, STEMI and STEMI, elective PCA, elective CABG. And we got that 90% of our patients failed to reach the LDL cholesterol target level below 55 milligram per deciliter. So it was really devastating to accept this data, because most of our patients actually failed to control the LDL cholesterol level. This is the Da Vinci study that demonstrates the current gaps in reaching between the two latest guidelines from ESC. It is concluded that only 33% of patients attained the overall 2019 goals of LDL cholesterol. There are several potential reasons for the failure to achieve this recommended LDL cholesterol values. First is the lack of familiarity with the latest guidelines from the healthcare provider, and high cost of medications such as PCSK9 inhibitors, and the patient's reluctant to be treated with the high intensity lipid lowering therapy, and the concern about statin related adverse event. So the authors conclude that even with the optimized statin, greater utilizations of non-statin lipid lowering therapy is likely needed to reduce this gap for patients at highest risk. It's also applicable in the several European or US countries, such as here in Germany. We see the quite similar data that patients didn't meet the LDL cholesterol target goal around 80%. And from the US data from 2011 to 2012, there are around 80% of the patients didn't meet the LDL cholesterol target goals. This is the latest guideline from the ESC. If you look at here, they are starting from the stratified the risk of every patient, and after that we can choose the several treatment choice, starting from the high potency statin therapy at the tolerable dose, and if it is still not reach the goals, we can add ezetimibe, and if it is still not reach the goals, we can add the PCSK9 inhibitor. This is the expected clinical benefit of lipid lowering therapy. For example, the high intensity statin therapy is assumed to reduce the LDL cholesterol around 50%. And if we put the PCSK9 inhibitor, it's assumed to lower the LDL cholesterol until 60%. If we combine PCSK9 inhibitor plus high intensity statin therapy, it was assumed to lower the LDL cholesterol for 75%. So what we've learned from this lipid lowering therapy scheme is the future perspectives of lipid lowering therapy. There are several potentials that still explore right now. First, the reducing LDL cholesterol with targeting the PCSK9 consists of RNA interference. The drug's name is inclisiran, and reducing the triglyceride-rich lipoprotein, such as the NG-PLT3 antibody, and increasing the level of HDLs, reducing the Lp(a) level with antisense. The process of LDL, if we look at into this scheme, LDL is carried in LDL particles in the bloodstreams, and the LDL receptors on the surface of hepatocytes bind with the clear LDL particle from the bloodstream. And there is a certain proteins called the PCSK9 that synthesized in the liver interfere with the regulations of LDL receptor. So the plasma LDL will become higher if this protein is in the high number. So the people start to think to inhibit this molecule or these proteins, the PCSK9, by PCSK9 inhibitor or by the single interferon RNA that disturb the process of making of the PCSK9. The inclisiran actually is a small interfering double-stranded RNA that mimics the body process of RNA interference. They will prevent the productions of PCSK9 protein by degradations of its mRNA. So this is the
No.
study that show to us that the primary endpoint of the different LDL cholesterol change in around 1.5 years after the inclisiran therapy, Orion 9, Orion 10, and Orion 11. It showed to us that significant reductions in LDL percentage with inclisiran versus placebo on top of maximally tolerated statin dose at 1.5 years. It's around 40 to 50%. And this is the threshold. If we look at here, if we set the threshold below 70, almost over 50% of our patients that got the inclisiran in Orion 9, Orion 10, and Orion 11 will reach their goals. And up to 75% of patients in Orion 10 and Orion 11 were able to achieve the guideline recommended LDL cholesterol below 70 milligram per deciliter with inclisiran. So I come into the summary. The first one, SCVD is a leading cause of cardiovascular disease morbidity and mortality. And the current evidence suggests that elevated LDL cholesterol is the most readily modifiable risk factors. And lowering the LDL cholesterol is directly leads to significant improvement of cardiovascular outcomes. And many patients that treated with statin-based lipid lowering therapy are unable to consistently achieve and maintain their LDL-C cholesterol target. And the inclisiran as the single interferon RNA helps to lower the LDL cholesterol that mimics the body process of RNA interference to increase the LDL receptors in the liver. I think that's all that I can deliver this afternoon. Happy to discuss with all of you. Thank you very much.
Thank you very much, Dr. Bambang, for the lecture. I think Dr. Bambang told us about the problems and then inertia, including the physician inertia, patient inertia, and regulatory inertia in reaching the LDL target in Indonesia and across the world. And I think, Dr. Bambang, do you have time for addressing one or two questions for the audience after this?
Yeah, sure, Dr.
Okay, since the committee told me that you have another program after this. So please, for the audience, participant, their colleague, professor, if you have question or comment about this topic, particularly topic from the Dr. Bambang, you can directly ask by the raise your hand or maybe typing in the chat room. Please, if any question from your side. If there is no, I have one question for you, Dr. Bambang. So we know in guideline, mostly all of the guidelines in the world, the PCSK9 inhibitors is put in the third line after statin, and then ezetimibe, yeah, and yeah, maybe for the first line only for the familiar homozygote, the hypercholesterolemia. Do you think that in the next future this class of treatment will go up, yeah, after statin, because statin is a robust data? Do you think the next future this class of drug will be put in the second line for the treatment of atherosclerosis cardiovascular and especially the lipid treatment?
Okay, thank you, Dr. Tri, for your interesting questions. I think looking back into what the clinical trials show to us about the PCSK9 inhibitors or PCSK9 single interferon RNA, it will be really promising in the future that this kind of treatment, lipid lowering treatment, will replace or will become more potent additional treatment beside the high dose statin that we use until right now. Because if you look at into the reductions of the LDL cholesterol, if we combine high intensity statin therapy with the PCSK9 inhibitor, we can lower the LDL and up to 75%. So it was really promising. And the second reason is because the patient's adherence. If we look at to the conventional therapy, lipid lowering therapy that we use right now, the oral treatment, we should consume every day. The next generation lipid lowering therapy, like the inclisiran, we only can be injected for the several months, for the interval of several months. So it's a very practical, I think, but I don't know about the price in when this kind of medications will arrive in our country. Maybe it will be very expensive, but for some specific populations, maybe it's very accessible, and it's a very practical to be used to as our weapon to lower our LDL cholesterol target.
Yeah, thank you, Dr. Bambang. Since we have some patient that totally allergy with the statin, all of the statin, so that's why we prescribe the patient to look for the PCSK9 inhibitor, especially the antibody that coming previously, Ali or Evolo in the neighbor country. So the patient is must buy the PCSK9 inhibitor to the outside of our countries, in this class of drug haven't yet available in Indonesia. I think thank you very much for the Dr. Bambang, and we move to the second speakers.
Thank you.
Thank you, Dr. Bambang. Second speakers that will be Prof. Muhammad Saifur Rahman, MD PhD from Universitas Brawijaya, that will share with us about the insight across cardiovascular continuum from atherosclerotic cardiovascularity to heart failure. Please, Dr. Bambang is, I think, the senior cardiologist and senior consultant in the cardiology in the Universitas Brawijaya, and also in he graduated from medical doctor from Surabaya Universitas Airlangga, and continue to have the PhD program in Japan and cardiologist, and also in universities Indonesia. Okay, Prof. Muhammad, I think time is yours, around 15 minutes about your topic, and we will directly discuss with our colleague. Thank you. Please, Prof.
Thank you, Dr. Trijuli. Good afternoon, everybody. Dear Professor, my colleagues, let me share the slide first. Can you see the slide?
Sir, good. And just put it in the slideshow manner, Prof. Yes.
This afternoon session, we like to discuss about the insight across cardiovascular continuum from SCVD to the heart failure. I'm Saifur from Brawijaya University. I've known the climber. As an outline, I like to discuss regarding the epidemiology and cardiovascular continuum, and then I will emphasize how the important risk factor control, as Dr. Bambang said, and also the continuum of progressivity heart failure resulting in high morbidity and mortality, and then we should know also the recent evidence of the treatment of heart failure by blocking the multiple pathway to prevent the progressivity, and also another challenge of the order of the treatment, how put into the practice. As we know, the burden of heart failure around the world is very high, and those heart failure patients also frequently come to the rehospitalization, and then the economic burden also very high, according to the first number spending insurance money. We are here in Indonesia. we have also a big problem such as other country, which is we see here the Indonesia is the one of the 5 the highest number of CVD deaths around the world, and we should also think about how to prevent the progression. My data in Saifullah Anwar Hospital also showing the trend of the increasing of the prevalence of and death, and we also noticed that the East Java province is also contribute to the most prevalent death because of the CVD. This is my data in Kabupaten Malang, showing the most prevalent of the cardiovascular disease, and unfortunately, most of them died at home, because as we know, the high burden of CVD in part caused by the high risk factors, including the hypertension, diabetes, and also obesity, accounting to the maybe around nearly 30% of the population suffer from the high risk burden of the suffering of CVD within the next 10 years. This is actually the scheme of the cardiovascular disease continuum proposed by Victor Zhou, emphasizing the importance from the beginning risk factor treatment control, including the cholesterol, hypertension, also diabetic. When the risk factor not well controlled, it is sure that by the time the patient come to the even whether becoming a develop of the LVH or ischemia or other even sudden death. That's why the effort supposed to be pay to attend attention of the treatment from the beginning of risk factors control, and then also surveillance for detect the event of cardiovascular event. This is the scheme of how the risk factor come to the event. By the time from the beginning, we should also control the risk factor and also give the patient with the best evident medicines provide to us to get the better outcome by giving the optimal guided directed medicamentosa. By this slide, you should know that the risk factor control is a must for every patient. Otherwise, the high prevalence of mortality and morbidity remaining high. Here we can see the natural history of the heart failure, whether we can see here by the time there was a declining of the functional capacity and also increasing of the mortality rate, because we know that the compensated state of the heart failure is the progressive disease. We can also know even in stable patient, the sudden death also happen accounting to the 44% of the population. We can compare to the other disease, fatal disease, such as prostate cancer, lung cancer, and also other cancer. Here we can see both in men and women, the heart failure accounting to the contributor of the mortality. Even when we see here by adding the optimal medicamentosa by combination of the ACE or IAB or beta blocker, or even additional of the antagonist of MRI, still remain 2 over 3 of mortality risk. It means we should try for our best to optimize the dose of the drug, and also by add other component of the inhibitors such as ARNI. We can see here, according to the pathway, the ARNI may inhibit the RAS pathway and also the neprilysin pathway. However, the outcome might also moderate result we get. Here we can see the recommendation how we can change from the ACE inhibitor to the ARNI in which setting. For example, according to the paradigm heart failure trial, the ARNI shown to be superior as compared to the enalapril, and reduction of the hospitalization mortality CVD did also notice. Therefore, in the stable ambulatory condition, we might change the ACE or ARB to the ARNI treatment. We can see here that from the beginning, we have now the step which drug supposed to be administered first. For example, ACE or ARB, and then we might add the beta blocker, and we may also add the MRA when the symptom remaining symptomatic. Importantly, also we might change to the ARNI, and for the last, we might also administer the SGLT2 inhibitors. But recently, and interestingly, the order of the therapies was changed. The guideline suggests that we could administer at once in heart failure reduced ejection fraction condition. We might put together ACE and ARNI, a beta blocker, MRA, and SGLT2 inhibitors, but only additional furosemide we add when we need. This is of course the new paradigm for us in clinical practice. The AHA guideline for American guideline also suggests that we might administer at once, put the SGLT2 inhibitors together with other regimen when we face the patient with reduced ejection fraction with the EF less than 40%. Then if it is remain symptomatic, we might administer the nitrate or hydralazine or ice device, whether ICD, CRTD, or other plan for the cardiac transplant for the advanced heart failure. It is actually interesting for us discussing about how the SGLT2 inhibitors work as heart failure treatment. Originally, this drug work as the component to inhibit reabsorption of glucose. Here we can see the absorption of the glucose. Reabsorption of the glucose is inhibited by SGLT2 inhibitors, so that the level of the glucose in the blood is reduced significantly, independent to the insulin pathway. And we can also know that the pleiotropic effect of the SGLT2 inhibitors here through the improvement myocardial energetic by increasing the cotton body formation, reliance of the fatty acid instead of the cardiac remodeling inhibition, and also improve the cardiac wall stress. Of course, the direct effect of the SGLT2 inhibitors resulting in the increasing fluid interstitial fluid and also reduction of the plasma volume and reduction also in vascular resistance. We know actually comparing to the normal heart, preserved ejection fraction, the heart failure with reduced ejection fraction have utilized more ketone. That's why the SGLT2 inhibitor, which is increase the content of the ketone, might also save the energy and save the heart and the clinical getting better. You might also see several recent articles published explaining how the SGLT2 inhibitors work as agent for left ventricular remodeling inhibitors, and also in other setting, whether in a diabetic patient or non-diabetic patient. This is actually the end of our slide. You might ask the question, how can we apply in the practice putting together SGLT2 inhibitors, beta blocker, ARB, and MRA? Of course, depending on the setting of different patient. For example, the patient with the blood pressure more than 90/60, we may use SGLT2 inhibitors, MRA, and reduce little bit beta blocker and ACE or ARNI dose. And those who have already heart rate of less than 60, we might reduce the beta blocker by also reduction of the stopping of this diuretic and putting together SGLT2 inhibitors and MRA as a fixed dose. As a summary, I like to conclude that we have facing a big problem regarding the mortality and morbidity of the ICVD around the world, also in Indonesia, and in our mind that CVD continuum, it is important to be considered because this is really continuum and progressing. Otherwise, we control the risk factors and progressivity by the progressivity by optimal medicamentosa. Other data explain also the link between uncontrolled CVD risk factor and disease progressivity and how high the morbidity and mortality was. The important also controlling the risk of ICVD might partly solve the other problem for development of the heart failure. And recent advent of heart failure management might result in a better outcome by putting together all inhibitors of many pathways, resulting in the inhibitor of the hormonal pathway, RAS, angiotensin system, and also SGLT2 pathway. Of course, in daily practice, we should consider the patient-by-patient condition. Personalized management must be applied according to the specific patient condition. And thank you very much for your kind attention.
Yeah, many thanks, Prof. Muhammad, for the inspiring lecture. And we directly go to the discussion session to the audience, I think. And I invite to the participant, the professor colleague, if any comment, if any question from your side, do not hesitate to raise your hand or directly deliver your question. And of course, in QA room as well. Yeah. Prof, this is any question, but actually this question for the Dr. Bambang, but I think if you don't mind, we discuss this question. Yeah, no, I think it's a daily practice. How about the challenge to reduce the LDL level between diabetic and non-diabetic or pre-diabetes? How do you think, Prof, about this question?
Yeah, thank you so much. Actually, we treat the LDL cholesterol not only not about the value, not about the number, but we actually treat the patient, of course. But according to the evidence that when the evidence collect together, the diabetic and pre-diabetic patient we treat as ICVD patient. It's setting off the same as CAD patient. This is the so-called the equivalent risk. It means who suffer from diabetic without CAD, it will be treated as the same as CVD in one's attacks. The probability of this diabetic patient to be occur even the same as the second attack of CVD patient. That's why the pre-diabetic patient and diabetic patient we put on the high risk at least. In a high risk condition, we put the target less than 70. Why? Because according to the imaging study showing by IFUS, intravascular ultrasound, and also by OCT, showing that at the level of more than 70 milligram per deciliter, it was progressing. Whether below of the 70, the plaque of atherosclerosis will be reduced significantly. That's why, especially for the high-risk population, we should put the target below 70. Thank you.
Yeah, I agree with you, Prof. So diabetes is a CVD risk equivalent. So that's why patient with diabetes, we put it at a minimally high risk for the CV risk. So we reduce the LDL less than 100 for the diabetes patient. Prof, I think, any another question? Yeah, maybe from the discussion in the many symposium, Prof, I think heart failures is close to the diabetes itself, and the choice of diabetes treatment also considering if any heart failure or not in the practice. So that's why we need to screen all of diabetes patients if any mild or early heart failure. And according to your opinion, what's the best tools, yeah, in diabetes patient to screen, yeah, the earliest detection for the heart failure in diabetes in your practice, Prof? Please, Prof.
Yeah, thank you, Dr. Yuli. It is actually very difficult question to be addressed. Anyway, in diabetic patient, we actually routinely ask the functional capacity of the patient clinically, whether the patient could perform the daily activity without symptom or not, or for further exploration about how can our patient performing the activity more than the usually, for example, taking steps upstairs, whether there was a symptom or not. Or in daily practice, we might screen by a treadmill, Dr. Julie. Treadmill actually mandatory in diabetic patient at least once a year, because by examination of the treadmill, we might detect the silent CAD, obstructive disease, and also we might assess the functional capacity to prescribe the patient to perform the daily activity according to the capacity of the function of the heart. Sometimes we incidentally identify patient with from the beginning suffer from the diastolic heart failure, easily fatigued patient, and when we do the stress test, it was actually appear that the patient have the difficulty in daily activity. That's why we try to see and optimize the treatment by prescribing the drug and also lifestyle, and also including the what kind of activity they might pursue to reduce the cholesterol, to control the diabetic, and also to train the heart every day. And then after when the patient has suffered from the early state of heart failure, you might explore to the presence of CAD by imaging, for example, by street mill. We can see whether the positive street mill test or not, and then you might perform the echo. From the echo, you might see the fraction, diastolic dysfunction, and also the abnormality of the valve. When the coexisting disease occur, for example, CAD, hypertension, or other disease, we might treat together. Thank you.
Okay, thank you very much, Prof. I think it is many experience and many new information from your side, and we reached the last of our time. And again, thank you very much, Prof. Prof. Saiful Rahman, for your coming here, and thank you very much for all of the participants. And I think I finished this symposium with Assalamualaikum warahmatullahi wabarakatuh, and back to the Master of Ceremony. Thank you, Prof. Thank you, colleague.
Thank you all.
Thank you very much for a very insightful presentation and discussion, Dr. Trijuli, Professor Saiful Rahman, and also Dr. Bambang. We also would like to thank the sponsor for this session, Novartis. So next session, we will start the Symposium 8 with the theme Herbal Medicine Research in Metabolic, Cardiovascular, and Aging, from Bench to Community. This session will be led by Professor Abdul Munim as moderator. Please allow me to read the curriculum vitae of Professor Abdul Munim. Professor Abdul Munim is from Department of Pharmacognosy, Photochemistry, Faculty of Pharmacy, University of Indonesia. He finished pharmacy in University of Indonesia in 1990 and became master at Universitas Gadjah Mada in 1997 and finished doctor at Tsukuba University in 2003. He is currently head of Department of Pharmacognosy, Phytochemistry, Faculty of Pharmacy, University of Indonesia. He is also former Vice Dean, Faculty of Pharmacy, University of Indonesia. He is currently lecturer in Department of Pharmacognosy, Phytochemistry, Faculty of Pharmacy, University of Indonesia. So without further ado, I would like to offer the time to Professor Abdul Munim. Good afternoon, Professor.
Good afternoon. Thank you, MC, for introducing my CV.
All right, I would like to offer the time to you, Professor. The time is yours.
Okay. Assalamualaikum. Good afternoon, all participants. In this session, we have three speakers. The first is Dr. Wisnu Anantakusuma. The affiliation is from Bioinformatics Cluster, IMERI Universitas Indonesia, and Department of Computer Science, Faculty of Mathematics and Natural Science, IPB University. He finished his bachelor and master from ITB, and then finished his doctor from Tokyo Institute of Technology. So currently, he is a principal investigator, Bioinformatics Cluster, Indonesian Medical Education and Research Institute. Okay, Dr. Wisnu, you already joined with.
Yes, Assalamualaikum warahmatullahi wabarakatuh, Prof. Muin.
Okay, you have 20 minutes for presentation, and after three speakers finish her presentation. Please, time is yours, Dr. Wisnu.
Thank you, Prof. Abdul Mut'im. I just want to share my presentation. Okay. Thank you. Good afternoon, ladies and gentlemen. I'm Wisnu Ananta Kusuma from Bioinformatics Core Facilities Emery Faculty of Mathematics. Faculty of Medicines, University of Indonesia, and also Department of Computer Science, Faculty of Mathematics and Natural Science, IPB University. In this conference, I would like to present our works entitled Network Pharmacology Approach to Natural Product Discovery for Diabetes mellitus. So there is our outline. Now, first, I would like to show the motivations of this work, and then give a brief description about the network pharmacology approach. And then I would like to show some of our research in network pharmacology, and finally we will summarize this talk. So about the motivations, as we know that diabetes mellitus affects many people worldwide, ranges from the age of 20 to 79, and is expected to rise to 100 million by 2045. And also in Indonesia, diabetes is more common in adult in Indonesia, with more than 10 million cases out of more than 70 million adult populations, and resulting in a case prevalence of 6.2%. As we know that in Indonesia, one approach to treating diabetes mellitus is to use natural ingredients. For example, it's many Indonesian community use the ingredients, natural ingredients, one of which is derived from the plants as herbal medicines. But actually there is a gap. The area of Indonesia tropical forest covers about 143 million hectares and home to about 80% of the world's medicinal plants. But according to Suhut et al., they identified that more than 180,000 species with medicinal potential in the forests of Indonesia. However, according to BPOM, we only have 20, maybe currently maybe more than this, but from the 2020 information, we only have 24 product of phytopharmaca and also 62 product of standardized herbal medicine. So this is the gap. And currently, there is a new approach, we call it as network pharmacology, actually derived based on the graph theory and or network theory, and also system biology, that are very popular to be used to solve the problems in a complex disease, for example, or complex dynamics, organic interconnections, and molecular systems. By using network pharmacology, we can draw on the interactions between, for example, drug and targets, drug and disease, and gene, and many other components. And by using drawing this or visualize this network, then we can analyze and also can reduce and can get a more important patterns inside the network, so we can get, for example, the most significant role, the most significant protein, for example, that related to specific disease. And also by using network pharmacology, we also can elucidate or explain the mechanisms of the herbal medicine, for example, for Kampo medicines or Jamu medicine of Jamu is Indonesia, Kambu is Japan's, and also maybe traditional Chinese medicines, we can elucidate the mechanism of multi-compound, multi-target interactions. For example, we expect that, for example, from compound, the first compound can have a main effects, and the second compound can have a supporting effects, and the third compound, for example, for reducing the side effects. This is very different with the mode of action of the ordinary or conventional medicine that use the one compound or one target interactions. And also there are some approach in the natural product discovery. The most common approach is the first common approach is, for example, started from the plant and then go to the lab work to conduct toxicity testing, in vitro or in vivo testing, and maybe in clinical trial. And the second approach is network pharmacology, but started from the plant side, or we call it as reverse pharmacology. We start from the very popular plant that already known to be used for treating some specific disease, and then we try to explore the mechanism of interactions between the compounds, the active component and target proteins using network pharmacology, and then analyze more by using some technique in network pharmacology to get the most important candidate of compound and then go to the lab work. And the third approach is network pharmacology approach, but started from the disease protein side. For example, from disease, then we try to find the most important protein target that have the significant role related to some specific disease, and then using this protein target to build the model prediction or prediction model using machine learning or deep learning to predict, for example, the interaction between herbal medicines and the target herbal compounds and the protein targets, and then could validating by using the docking molecular and then go to the lab work. This is some research in the pharmacology or research. Some example of the research. First, actually, this is the research from the Dr. Fadila from the head of the Bioinformatics Core Facilities and Emory Faculty of Medicine, University of Indonesia. The study investigated the mechanism of non-phytochemical constituent of Tinospora crispa and its interaction with protein targets involved in insulin resistance. Firstly, we collect the data set, the Tinospora crispa's chemical constituents, protein target involved in insulin resistance, and also protein target of Tinospora crispa phytochemical constitution from many databases, and then identify the significant target proteins related to insulin resistance from protein-protein interaction network by using some techniques, for example, using machine learning or clustering, unsupervised learning, and maybe to also the other algorithms, and predict the Tinospora crispa constituent target genes and their intersection on insulin resistant related targets, and then conduct some process like network pharmacology analysis and treatment analysis and molecular docking and molecular dynamics analysis. And this study yielded obtained some result compound candidates that target some protein. And if we look at more detail to the pathway, then we can show the information that regulation in glucose homeostasis, adipolysis, cell proliferations, and also anti-apoptosis are predicted to be the critical mechanism of Tinospora crispa as an insulin synthesizer. This is the second work. This is our work in IPP University and also with the STIF Makassar. This try to elucidate the mechanism of Kokuliku in treating diabetes mellitus. And curculigo actually is a herb that is commonly used in Indonesia to treat diabetes mellitus. And the main active compounds of curculigo were identified through metabolomic study. So we conduct the metabolomic analysis using LSMS and also collect another compound from the database, the other database. And this study. In the study, a network formula was used to explore the active compounds of curculigo and their potential molecular mechanism for treating diabetes mellitus. And this is actually the visualizations of network construct from the curculigo data. We have showing the interaction among the chemical compounds from the curculigo, and then also protein target associated with specific diabetes mellitus, and also the other protein targets, and also pathway and disease. And if we look at into more detail, then we have three compounds from the curculigo that target the protein, and if we look at more detail in the network, then we can get information that actually the first protein PTPN1 related to the type 2 diabetes mellitus and also obesity. And for the second protein, this actually related to type 2 diabetes mellitus and metabolic disorder. And the third protein actually related to the metabolic disorder and non-insulin dependent diabetes. And this is the third work. Actually, this work is different with to previous work. This work actually try to use network pharmacology as from the perspective of computer scientists. We know that network pharmacology can form a relationship between plants, compounds, and target proteins, but there is a problem in finding combinations of, for example, herbal formula or jamu formula because of the increase in source space size. For example, if we have many plants and then we try to combine many plants to get the optimal formula of jamu. So and also the target interaction, many people use many researchers use the drug target interaction implemented using machine learning or deep learning, but this is also have important issues such as imbalanced data sets and also high dimensionality and also overfitting. So we propose an alternative approach by implementing bipartite graph search optimizations using branch endpoint algorithm to solve this problem. So our approach actually started by expanded the drug target interactions into bipartite plant proteins and then transform them to 1-0 knapsack problem. Actually, 1-0 knapsack problem in computer science is an NP problem. NP problem, actually, there is no polynomial time algorithm that can be found to solve the problem. So we should use the heuristic approach, and we use graph traversing algorithm with the branch endpoint technique to perform tree search to find medicinal plants for certain disease. Firstly, we collect many data sets, plant and compound, target protein, and many data sets from many databases, and then construct 3 networks. The first network is connected plant, compound, and protein. The second network is consists of compound, herbal compound and proteins, and the third is consists of the disease, protein target, and compound. And we try to connect the 3 networks into one because we would like to traverse or to visit all of the node from the disease to the plants. So we connect using based on the similarity matrix or similarity measure between compounds and between proteins. And the objective is actually to calculate the protein weight and the weight of each that connected compound to protein. So then we can get the plant that have the higher or the highest score or with because of the traversing from the disease to plants. So we implement the three techniques. The first step for search, we start from root to leaves, from top to bottom, and then back to top, and then go to the bottom again until all of nodes will be visited or have been visited. And the second technique is Bradford search from root to right and then to left until all of nodes has been visited. And the third approach is best for search. This is actually the visiting nodes based on the optimal value of the node. So this is the result of our work. Actually, there are two combinations of plant or formula, 3 and 4 combination, and 4 combination. We have Angelica sinensis, Citrus aurantium, and Glycyrrhiza uralensis, and Mangifera indica that targeted certain proteins related to type 2 diabetes mellitus. And we use literature study to validate this result. From Lee and Chen, we know that the polysaccharides contained in Angelica sinensis and can significantly reduce blood glucose level and improve the clinical symptoms of type 2 diabetes mellitus on the rats. And Gia et al. Reported that hesperidin from Citrus aurantium helped increase oral glucose tolerance and insulin sensitivity. And Glycyrrhiza uralensis can also be used for type 2 diabetes mellitus treatment and prevention due to its flavonoids containing alpha-glucosinase and PTP1 beta inhibitory activities. And Ngo et al. Showed that Mangifera indica leaves extract contained potential hypoglycemic and antioxidant properties, which could be beneficial for type 2 diabetes mellitus. But in this case, we did not conduct synergicity testing. So this is maybe the weaknesses of the work. For the summary, we can summarize this talk that the network pharmacology can be a promising method for elucidating the mechanism of interaction between natural compounds and target protein associated with diabetes mellitus, and to discover natural product formulas more accurately. However, a series of preclinical and clinical testing must be carried out to validate the potential natural compound candidates. So all the computational method actually only give the result as hypothesis. So we should need the lab work, for example, in vitro or preclinical or clinical testing for validate our result. This is actually the ongoing research from the bioinformatics core facility. There are some topics like such that network pharmacology in COVID-19 cytokine storm and inflammatory and extract spirulina plant disease and the other topics. And this is our contributor, Dr. Fadila for Emory FK, Faculty of Medicine, University of Indonesia, and also there's from the STIF Makassar, and most of them is from the IPP University. Thank you for this talk. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Okay. Thank you. Very interesting lecture about the network pharmacology from Dr. Wisnu. Okay, the next, the second speaker is, Professor Tatsuya Marimoto from Shizuoka University, and she will talk about novel heart failure therapy using natural compound, curcumin. So before he talks, we would like to introduce this CV. Prof. Tetsuya Marimoto is from division, division of Molecular Medicine, School of Pharmaceutical Sciences, University Shizuoka, Japan, and he finished medical doctor and also PhD from Kyoto University, and currently he is a professor and chairman division of Molecular Medicine and School of Pharmaceutical Science, University Shizuoka. Okay, times is your.
Yes, thank you.
Marimoto.
Yes.
Okay. Yes.
Okay. Thank you, Chairperson, for the kind introduction. I would like to thank the organic committee for giving me this opportunity to make a presentations. Today, I'm talking about cardiac nuclear signal pathway and curcumin, a novel therapy agent for heart failure. This is my COI. As you know, heart disease is the world's biggest killer. Heart disease such as myocardial infarction, hypertensive heart disease, and arrhythmia finally result in heart failure. A variety of stress on the heart, such as myocardial infarction, hemodynamic overload, activate the neural factors, such as factors sympathetic nervous system and renin-angiotensin systems. These factors initiate a number of subcellular signal pathways, which finally reach the nuclei of cardiac myocytes and change the pattern of gene expression associated with hypertrophy. This causes cardiac myocyte hypertrophy and eventually leads to system dysfunction or decompensated heart failure. To establish an effective therapy strategy for heart failure, we have a common nuclear pathway within cardiac myocytes. We found that during myocardial hypertrophy, P300 histone acid transfer activity is enhanced. P300 can induce the acetylation and then binding of GATA4. Activation of GATA4 upregulated cardiac hypertrophy response transfusions. The precise role of P300 heart activity in vivo is unclear. We use a mutant P300 in which double amino acid substitution mutation are introduced. This mutant is almost completely defective in not only histone acetylation, but also transfactors acetylation. To investigate the role of P300 heart activity in LV remodeling after myocardial infarction, we generate transmass overexpress intact P300 or heart mutant P300 in the heart. LV remodeling after myocardial infarction are more exaggerated intact P300 transmass than in wild-type mice. In heart mutant P300 transmass, however, the LV remodeling was attenuated, almost same as in wild-type mice. So this is our hypothesis. Hypertrophy stimulation upregulates P300. Upregulated P300 can activate not only histone, but also cardiac space transfactor GATA4, increase its DNA binding ability and promote the hyperresponse transmission. This induces myocyte hypertrophy and heart failure. For heart mutant P300 is unable to induce acetylation and DNA binding GATA4 and prevent the development of myocyte hypertrophy and heart failure. So this suggests that heart activity of P300 could be a formal target for LV remodeling after myocardial infarction in humans. So therefore, it would be interesting to test whether P300 heart inhibitors can prevent the development of cardiac hypertrophy and heart failure in vivo. A few histone acid transfer inhibitors are known so far. Recently, a natural compound curcumin was reported to be a P300 specific heart inhibitor and have cell permeability. A curcumin is a polyphenol that is responsible for the yellow color of the Indian curry spice turmeric and is commonly used in a healthy food diet. Curcumin is known for its many properties, such as antitumoral and antioxidant properties. We use this curcumin to investigate whether this can inhibit the cardiac hypertrophy and heart failure. In a model of hypertension, heart disease, persistence of hypertension causes from concentric hypertrophy to heart failure. We found that heart activity of P300 is enhanced and play a role in developing system dysfunction. Furthermore, in the myocardial infarction model, P3 heart activity is upregulated and play a role in the transition from compensatory extended hypertrophy to heart failure with reduced systolic function. Curcumin inhibits cardiac dysfunction in both models by suppressing the heart activity of P300. Curcumin might be used as a drug for improving left ventricular function. To apply this novel therapy in the clinical setting, it should be clarified whether curcumin possesses additional effects on conventional therapy, such as angiotensin-converting enzyme inhibitors. Therefore, we examine the effect of ACE inhibitor and curcumin combo therapy on heart failure after myocardial infarction. In rats, LV frag shortening was significantly higher in the ACE inhibitor enalapril and curcumin group than in the vehicle-treated group. Notably, LV fraction shortening significantly increased by enalapril and curcumin combo therapy than compared with monotherapy, either enalapril or curcumin. So, unnatural compound curcumin had a beneficial effect on LV function after rat myocardial infarction in addition to ACE inhibitors. Thus, this non-toxic diet compound will apply to heart failure therapy in the clinical setting. So there is a problem with curcumin to apply in clinical settings. As indicated here, plasma curcumin level by oral elimination in humans are very low. This low absolute efficiency of curcumin is due to its poor water solubility. So the more crucial issue for curcumin is to improve the bioavailability. To improve the viability of curcumin, we performed two strategies. First, we performed structural activity relationship study to identify the curcumin derivatives which possess stronger activity for heart failure therapy than curcumin. Second, we create a curcumin preparation with a drug delivery system DDS that improve oral absorption. First, I would like to show the result of structural active relationship study. In addition to curcumin, which have two methoxy groups, curcuminoid contains the dimethoxycurcumin, which has a single moiety, a single methoxy group, and this methoxycurcumin, which has no methoxy groups. Tetrahydrocurcumin and curcumin glucuronide as a major metabolism of curcumin found in the plasma after oral elimination of curcumin. We perform a structural activity relationship study using these compounds. These are the result of the in vitro heart assay and the inhibitory effect of phenylephrine-induced cardiovascular hypertrophy. Dimethylcurcumin and this dimethylcurcumin have almost the same inhibitory effect on heart activity and phenylephrine-induced cardiovascular hypertrophy as curcumin. So these just suggest that these methoxy groups are not involved in the inhibitory effect of curcumin on P300 heart activity and cardiovascular hypertrophy. On the other hand, these metabolites, tetrahydrocurcumin and curcumin glucuronide, have no effect on P3 heart activity and phenylephrine-induced cardiovascular hypertrophy. Thus, inhibition of curcumin metabolism may increase curcumin's bioavailability. Next, we analyze the curcumin, curcumin derivatives, pyrrolidine and pyrazole derivatives were synthesized and provided by Professor Appendino. we examined whether these two prednisone derivatives can improve the PCSK9 heart activities. So curcumin can directly inhibit the PCSK9 heart activity in cultured cardiomyocytes. On the other hand, prednisone cannot directly inhibit the PCSK9 heart activity, but can indirectly inhibit the PCSK9 heart activity by suppressing the binding between CDK9 and cyclin T1, and then the kinase activity of CDK9. Moreover, prednisone inhibits activation of RNA polymerase, which plays an essential role in the transcription elongation by suppressing CDK9. So these data indicate that prednisone suppress both activation by heart activity of P300 and transcription elongation activity by inhibiting the CDK9, so that prednisone can suppress cardiomyocyte hypertrophy more strongly than curcumin. So prednisone could be a better medicine for heart failure therapy than curcumin. Next, we examine the 5 curcumin analogs indicated here. These analogs were provided by Dr. Shibata, Kita University. First, we examine the beta-glucan moiety in the curcumin skeleton were investigated. We use Y022, the structure of which has been changed from beta-glucan to monomoiety in the curcumin skeleton. In vitro assay revealed that Y022 had approximately the same inhibitory effect as curcumin. This finding suggests that the beta-glucan moiety of curcumin is not involved in the inhibitory effect of curcumin on P300 heart activities. Then, to investigate the effect of functional groups adapted to the aromatic rings to curcumin, Y030, Y031, 41, and 78 were used in the in vitro heart assay. Among all analogs, P3 heart activity was mostly strongly inhibited by Y030, which has 4 methoxy groups. The IC50 for P3 heart activity inhibition of Y030 was 1.1 micromolar, while that of curcumin was 9.5 micromolar. Thus, Y030 had 8.5 times higher P3 heart inhibitory activity than curcumin. So immunofluorescence staining reveals that 1 micromolar of Y030 significantly suppressed phenylephrine-induced increase in the surface area of cardiomyocytes, whereas 10 micromolar of curcumin was required to have the same effect. As Y030 strongly suppressed cardiomyocyte hypertrophy, it is likely that Y030 also prevents development of cardiac hypertrophy and heart failure in vivo. So to investigate the effect of Y030 on systolic function in vivo, a pressure overload-induced heart failure model in transverse aortic constriction mice was used. These panels show the different photographs of wave model images from vehicle, curcumin, and Y030 treated TAC mice. TAC mice, flank shortening after 8 weeks of operation was significantly decreased, and posterior wall thickness was increased in TAC mice compared to sham mice. So these changes were significantly suppressed by 50 milligrams of curcumin. And surprisingly, 0.5 milligrams of Y030 also suppressed them to the same extent as 50 milligrams per kilogram of curcumin. So the curcumin analog Y030 prevent TAC-induced cardiomyocyte hypertrophy heart failure at a lower dose than curcumin due to its potent P300 heart inhibitory activity. Thus, Y030 may overcome the poor variability of curcumin and be used for heart failure therapy more effective than curcumin. Further study is needed to clarify its future clinical use. So next, we introduce the result of the DDS curcumin. We generated a highly absorbed curcumin ferrochromine by making a submicron particles and sterilizing in water. The plasma level of curcumin in rats treated with DDS curcumin ferrochromine were approximately 60 times higher than those treated with native natural compound curcumin. Moreover, plasma curcumin concentration in humans administered with ferrochromine were 27-5 and 27-fold higher than those with curcumin powder. Then we examine whether this DDS system is useful for heart failure therapy rat with myocardial infarction. At a dosage of 0.5 milligram per kilogram, this curcumin, but not natural compound curcumin, leads to left ventricular systolic fraction shortening in post-myocardial infarction rats. Thus, this DDS strategy will be applicable to the clinical setting in humans. So continuation of high blood pressure in patient leads to left ventricular hypertrophy. Development of left ventricular hypertrophy results in left ventricular diastolic dysfunction. Diastolic function is estimated by echocardiography. E over E prime, a clinical parameter for LV stiffness, is usually used to examine the diastolic function. This panel indicates the protocol of clinical study. Hypertensive patient with left ventricular hypertrophy, normal systolic function, and reduced left function were enrolled. 69 patients were administered with placebo for 24 weeks. 73 patients were administered with highly absorbed curcumin, 90 mg twice a day for 24 weeks. Primary endpoint were E over E prime, a parameter for diastolic function, and BNP. This table shows the result of our clinical study. The percent change in BNP was significantly lower in curcumin group than in placebo group. So this is our conclusion. We provide the first evidence that highly absorbed curcumin, ferrochromine, improves BNP levels, a biomarker of heart failure in hypertensive patients with left ventricular hypertrophy. Further large-scale clinical trials are needed to establish heart failure therapy using curcumin. So we have been developing a better curcumin formulation than ferrochromine and succeeded in developing a new curcumin formulation. This formulation increased the blood curcumin level in humans approximately 3.5 times higher than ferrochromine. So we found that new curcumin formulation ameliorates the decrease in systolic function, fraction shortening, after myocardial infarction in rat at a lower dosage than ferrochromine. As with ferrochromine, we intended to continue our clinical trials with this new formulation. So this presentation was made possible by the cooperation of many micro researchers. I would like to take this opportunity to thank them. Thank you very much for your attention.
Thank you, Professor Marimoto. It's very interesting new information about application of curcumin for heart failure. So for all participants, if you have any question, please write in chat box, or you can write in QA session. The last speaker is Professor Wawai Muli Arozal. Before her talk, I would like to introduce her curriculum vitae. Professor Wawe Muli is a lecturer in Metabolic Disorder, Cardiovascular, and Aging Cluster, IMERI, Faculty of Medicine, Universitas Indonesia. He finished her PhD in Niigata University in Japan. And now she is a senior investigator in Metabolic Disorder, Cardiovascular, and Aging Cluster, IMERI, Faculty of Medicine, Universitas Indonesia. Okay. Professor Waimuli, you have 20 minutes for presentation. Okay. Time is yours.
Thank you very much, Prof. Munim, for the nice introduction. So good afternoon to everyone, professor and the colleague in this prestigious meeting. So first of all, I would like to thanks to the committee that invite me to this symposium. So today I would like to talk about the potential product of medicinal herbs in metabolic, cardiovascular, and aging. So from bench to bedside approach. But today I only will share about mainly about the preclinical and clinical study. So in vitro and in vivo study. Okay. So this is the outline of my talk. So I briefly talk about the pathophysiology of aging, and then I will briefly talk about some herbal usage in metabolic, cardiovascular, and aging. But because of the limitation of the time, so I only focus for about 6 herb medicine that usually popular in Indonesia, namely the cinnamon, or we call it kayu manis, turmeric. Yeah, previous speaker already talked about the curcumin or turmeric, and then I will talk about the mangosteen, and then jati Belanda, or in Latin name West Indian, Javanese long pepper or cabe Jawa, ginseng, and ginkgo biloba. I think even though the ginseng and ginkgo biloba is not originated from Indonesia, but these 2 herbs is very popular in Indonesia. So we can easily find it in, for example, in online market. Yeah. So I would like to emphasize some evidence about these 2, and then I will also notify about the side effect of these 2 herb medicine. Yeah. So this is the pathophysiology or the pathogenesis of cellular senescence. I think it is everyone already know about the morphological and metabolic change in senescent cells, that there are many markers of cell senescence, include change in beta-gal activity that can caused by increased lysosome content and activity, the loss of lamin B caused by the change in the nuclear envelope, the increase of lipofuscin labeled by Sudan black biscuit, and the morphological change such as flat cell bodies. So we also established that there are some markers for cellular senescence, such as SASP. Yeah. So nowadays, common researchers are for cellular senescence and related nutritional intervention. They use many kind of cell models, like endothelial cells, and then fibroblasts, cardiac muscle, and nerve cell models. So there are many variety of plants extracts with effective anti-aging properties have been identified. That many herbal extracts exhibit also anti-aging effect. So those kind of natural nutritional intervention for cellular senescence mainly included the carbohydrate, polyphenol, peptides, sterol compounds, and also the vitamin. Yeah. So the herbal preparation can exert protective effects by ameliorating the pathological effects exerted by cardiovascular disease risk factor. The herbal extracts can attenuate endothelial dysfunction and or vascular smooth muscle cell alteration by acting as even a vasodilator, ROS scavenger, antioxidant, anti-inflammatory, anti-apoptotic, anti-hypertrophic, or anti-proliferative agent. So this one can decrease the incidence of atherosclerosis and hypertension, which in return can decrease the risk of CVD development. So now I would talk about the one by one, the herb that also popular in Indonesia. So this is cinnamon, yeah. So usually in Indonesia, we use it as a spice, yeah, in the food. Okay, so the cinnamon, there is some evidence that it has proof that have a mechanism of action for diabetic. So actually the active compound of for diabetic is cinnamaldehyde. That there are many studies reported both in vitro and in vivo studies that the mechanism of action by which cinnamon can have a beneficial effect for diabetic is by increasing the autophosphorylation and decreasing the phosphorylation, and also can induce the GLUT4 translocation via AMPK, and further also can increase the GLUT1 mediated glucose uptake, increasing the GLP-1 level, and also increasing the PPAR gamma and alpha. In the gastrointestinal, so it also can inhibit the pancreatic amylase and intestinal sucrose. Okay, this study is meta-analysis. So as you know that there is very rare researchers want to do the meta-analysis for in vivo study. Mainly the researchers only do meta-analysis for the clinical trial. This is the challenge for us as a basic researchers, that we have to create as much as possible the meta-analysis for a specific candidate of the herb medicine. So in this meta-analysis, they analyze about 16 studies. Yeah. So the result of the meta-analysis show that the cinnamon can attenuate diabetes associated with loss, and then can reduce the fasting blood glucose and glucosylated hemoglobin, and then also can reduce the LDL level and increase the HDL cholesterol level. So again, this is all 16 studies by in vivo. Okay, so now we are looking at the clinical situation. So actually there are only about 6 clinical trials using the cinnamon for diabetes. So, but if you can see the total number of patients is only less than 50, about 30 to maximum 55. So I mean the quality of this clinical trial is not so good. Yeah. So for the result from this meta-analysis conclude that the cinnamon can have a significant decrease in the mean of hydroxylate hemoglobin into 0.1%, so only less, yeah. And then it also can decrease the mean of fasting blood glucose. Yeah, so this is this literature recently published in 2021. So they do the clinical trial on cinnamon as an adjuvant therapy, not as a single treatment, but adjuvant with the standard therapy. So in this trial, so we can see that the result of this trial, that the participant that got 3-gram capsule of cinnamon or placebo. So after 3 months, there is a statistical significant reduction of glycolated hemoglobin. So I think for the herbal medicine, it took time, it took time to get the beneficial effect. Okay, so how about in Indonesia? So cinnamon is already accepted as a phytopharmaca in Indonesia for indication of diabetic. So there is commercially available 75 milligram of cinnamon. So it is coming from Cinnamomi burmi cortex, and then it is combined with the other herb, namely the daun bungur or Lagastromiae. Yeah. So under the trade name is DLBS 3233. So from the in vivo study, it is proven that this kind of drug can increase glucose uptake by mediating up regulator of PPAR alpha, yeah, and then also an insulin sensitizer and on fructose-induced insulin resistance. Right. There is also evidence from clinical trial. There is an open trial. Recruited about 50 patients. That inadequately controlled by metformin and other oral antidiabetic. So the result of the study confirmed that this kind of drug can decrease the glycosylated hemoglobin, then also fasting plasma glucose. And then the other clinical trial is to treat this herb for pre-diabetic patient. So this study is 2-arm and prospective and double-blind, also randomized control. And the result of the study is confirmed that this drug can decrease the HOMA-IR and decrease insulin postprandial. Okay, now I further continue with the turmeric or curcumin. So previous speaker already explained about the chemical structure of curcumin. Mainly it is, there are three kind of active compound in curcumin, not only curcumin but also demethoxycurcumin and bis-demethoxycurcumin that have pharmacological activity. Okay, so what is the mechanism of action of turmeric in aging? So in organism level, it can reduce inflammation and generate a state of low chronic inflammation, SSTP. And then in cellular level, it can elevate the activity of anti-aging protein. Okay, this figure show you the proposed mechanism by which curcumin may have a protective effect in age-related cellular senescence. That we know that a hallmark of aging, one major risk factor for cardiovascular disease is the cellular senescence, which is associated with oxidative stress in blood vessel along with decreased levels of enos, nitric oxide bioavailability, reduced vasodilatation, and increased vascular stiffness due to the increased collagen-1 level. So it seems that curcumin can antagonize this effect by upregulating the SIRT1, NRF2, and downregulation of P43 and P21 pathway. So next, the possible mechanism of protective effect of curcumin in obesity-induced adipose tissue dysfunction is by upregulating the PPAR gamma, PGC1 alpha, and UCP1, resulting in an increase in mitochondrial biogenesis and also improve respiratory chain function and thermogenesis. So moreover, curcumin also can induce an increase in adiponectin levels in concomitant decrease in leptin, thereby also reducing the inflammation. And this figure show you the protective functional effect of curcumin that also have beneficial effect in inflammation in the cardiovascular related disease, namely the atherosclerosis. That because of that atherosclerosis is linked with the inflammation. So as you know that the curcumin has also potent anti-inflammation. So it also will inhibit the lipid peroxidation and then inhibit the increase of triglyceride and inhibit the increase of cholesterol. So by this figure, we can conclude that the curcumin may have a pleiotropic effect. Yeah. So I think the previous speaker already mentioned about the new formula of curcumin. Maybe it will be very beneficial for the inflammation in cardiovascular disease. So, because of we know that the negative of curcumin is based on the law of bioavailability. Okay, next I would like to talk about the Garcinia mangostana or mangosteen. So this is the queen of fruit, yeah. So, but the active compound of the fruit is not in the fruit itself, but in the peel, yeah, or in the pericarp, because of it is rich of the pharmacological activity, namely mangosteen or alpha mangosteen. So actually, this kind of mangosteen has a lot of antioxidants, so total phenolic content and also total flavonoid content. And then mainly it is in the rinds, yeah, or in the skin. Okay, so there are a lot of also in vivo preclinical evaluation of mangosteen, but mainly they talk about the antioxidant activity. And I cannot find mangosteen in the clinical trial for metabolic and cardiovascular usage, but I only found one indication of mangosteen for COPD patient that it can be useful for reduce in acute exacerbation. So the addition of mangosteen pericarp extract at the doses of 1,000 milligram per day during hospitalization was significantly lower plasma level of interleukin 6.
Excuse me, Prof. Your types.
Okay. Yeah. So I think now I would like to explain about the Jati Belanda. Yeah. So Jati Belanda, I think it is also commonly used for anti-obese. Okay. So this is the in vitro study related to the anti-diabetic effect of Jati Belanda. And this is the proof of preclinical evaluation of Jati Belanda in obese mice model. Yeah, I found there is a RCT by some other researchers that the Jati Belanda can decrease the waist circumference and then also decrease the fasting glucose and decrease also the glycosylated hemoglobin. Okay, I would like to show also the clinical report from our country that so one center they give the patient for traditional medicine. So they found that the jamu it's contain of Jati Belanda and then also the other leaves, yeah, Cassia sena, Sonchus arvena leaves and Camellia and etc. Not only one Jati Belanda but also combined with the other herbal. So they found that after 1 month the plasma cholesterol level was reduced from baseline. Okay, so this is I would like to show you about the cabe Jawa, yeah, Japanese long pepper. So the active compound is piperlongumine. Yeah, so it is also rich of antioxidant properties. Okay, in the in vivo preclinical evaluation, the Japanese long pepper seems can inhibit the hypertrophy in the heart tissue. And then I found one clinical trial related to the cabe Jawa, but it is not for indication of cardiovascular disease, but to as an androgenic phytopharmaca for male hypogonadism. Okay, now I would like to briefly talk about the ginseng. Yeah, so I think everyone, I mean, in Indonesia also this kind is very popular, even though it is not coming from Indonesia. So this mechanism action of CVD is by increase the eNOS expression and also inhibit the ACE activity. Yeah, and then in HRAT also it is have a potential for antioxidant activity. But in meta-analysis provided in 2016, they show that no significant difference in HbA1c levels between the ginseng supplementation and the control group. And then also no difference in postprandial glucose or fasting insulin, but only improve the fasting glucose. Okay, so I would like to emphasize the adverse effect and drug interaction of ginseng, that there are some adverse effects, mainly in long period, such as morning diarrhea, skin eruption, and etc. And then we have to consider about the drug-drug interaction between ginseng and warfarin. Then it can be reduce the plasma warfarin level. Okay. Finally, I would like to talk about the ginkgo biloba. So this is
maybe due to limited time.
Okay.
You can presentation.
Yeah. So this is the last slide. The ginkgo biloba in clinical setting. So mainly the clinical trial provide that the ginkgo biloba can be used as a adjuvant therapy for relief angina. And also in the combination with the metformin, it can also give a beneficial for uncontrolled type 2 diabetes patient. Yeah, so this is the adverse effect of the ginkgo biloba. Then it can be a drug interaction to have major bleeding events. Yeah, sorry for thank you very much for your attention.
Thank you, Prof. Wawai Muli. Many new information about development of herbal medicine in Indonesia. Already talked. Okay, I would like to invite all participants to give if you have any information, if you have any question, you can raise your hand or in chat box. Please.
Prof. Munim.
Oh, in chat box. Hello.
Prof. Munim.
Okay.
Hello. So may I ask question to Tatsuyo Morimoto Sensei?
Yes.
Yeah.
Yes, please.
Morimoto Sensei, it's very nice that your lab create the new formula for curcumin, right?
Yes.
So yeah. So I mean, this kind of formula is registered as a drug or as a herb in Japan. So this is my first question. And then the second one related to your clinical trial. So you perform the clinical trial for hypertensive patient, right?
Yes.
It is only one treatment, or it is add-on with the standard therapy?
Thank you very much. Good questions. Almost all patients have take antihypertensive medicine or the diabetes medicine. So this is just add-on, curcumin just add-on the effect, which checks the effect of curcumin just add-on therapy. Thank you very much.
Okay, thank you, Prof. It's clear, Prof. Pawai?
Yeah. About the this kind of drug, it is registered or marketed as a drug or a herb in Japan?
Thank you very much. Recently, difficult to perform the clinical study using the functional foods. It is completely inhibited by government. So we have another way to test the functional food. Maybe it will be performed in the United States or Europe. That is very easy to perform the clinical trials using these compounds. Thank you very much.
Okay.
Thank you.
Prof. Morimoto.
Yes.
We have one question in chat box from Mente Rati. Maybe the question from Prof. Pawai maybe. This is there any research regarding the potential for natural ingredient mentioned like turmeric or mangosteen to be used for tropical road, for example, diabetic wound? Maybe this is a for Prof. Pawai. Is there?
Yeah, topical road. Yeah, so it's very interesting. Yeah, if we can perform the herb medicine in the form of topical preparation. So, but unfortunately, our lab don't have capacity to develop the kind of preparation. So maybe Prof. Mun-I, maybe you are expert in the formulation. So I think it's possible, yeah, because of mangosteen or turmeric, it is have anti-inflammation activity. So if we can develop the topical preparation, it will be very beneficial for ulcus diabetes, for example, or like wound, burning, and etc. Okay, sorry for not perform until now to develop the topical preparation.
Okay, thank you. In my opinion, maybe the topical preparation is the requirement from BPOM is only lower requirements, so maybe it's perfect to develop a topical herbal product. If there are no question or I send from Agian Jeffliano, please.
Yes, thank you very much, Prof. Abdul Munim. So thank you very much for the wonderful presentation. So I would like to ask the question to Professor Morimoto and also Professor Wawemuli and maybe later Dr. Wisnu. So regarding the curcumin, so have you analyzed the toxicity in each organ or in the whole body in the preclinical data, for example, for Professor Morimoto, or in the clinical data, maybe in Professor Arozal? Is there any reference about that? And also maybe for Dr. Wisnu, how about the network pharmacology of the curcumin in metabolic disease? Thank you very much.
Thank you very much. It's a good point. So we performed the clinical trial using the DDS curcumin, but we have no side effect or adverse effect observed. So that might be the safe. Thank you very much.
Thank you, Professor Wawemuli.
Yeah. Prof. Wawemuli, please.
Yeah. Would you like to repeat again the?
Is there any reference or data about the toxicity of curcumin?
Toxicity, yeah. Oh, okay, toxicity. Yeah, toxicity of the curcumin. I think it is just mild. Yeah, mild. I mean, there are many reports related to LD50 and then subchronic toxicity of curcumin. So the curcumin that already in the market, it is extremely safe. Yeah. But the toxicity found reported that only gastrointestinal symptoms like vomiting and the diarrhea. Yeah, because of there are a lot of published paper related to the subchronic toxicity and the LD50 data. So in the market, the dose of the curcumin is very less than the LD50 or the subchronic toxicity level.
Thank you very much. And maybe last question.
I would like to ask. I would like to add some information related to the side effect of the curcumin because of there is some also evidence that if it is combined with the anticoagulant drug like aspirin or clopidogrel, maybe it can induce the possibility to get a bleeding. So it should be precaution for the patient and also the doctor. Thank you.
Okay, thank you, Prof. Wawan. Is enough, Agian?
Yes, thank you very much.
Thank you. In chat talk, we have one question for Prof. Wawan. Is there any research about the role of cinnamon on the prevention of type 2 DM? Maybe it's we consume in daily. Okay, this is from Sahidatul Wafa.
Okay, Ms. Wafa. So as I mentioned in my PPT, so the cinnamon is already marketed as a phytopharmaca. So it means it can be used of only for good for two indication, pre-diabetic patient and then diabetic patient. For diabetic patient, it should be add on with the standard therapy. But for pre-diabetic patient, it can be used as a single therapy. So, I mean, from the literature said that it can inhibit the progression of the patient to become type 2 diabetes. So it can be consumed daily. As I mentioned, there is in phytopharmaca. So it is, if I'm not mistaken, is once capsule daily. So, but we have to use it for long term. Yeah. So we can get the result after 1 and 2 months, something like that. Thank you very much.
Okay, thank you. Okay, I have one question for sorry. Network pharmacology. I think this is very interesting result, and Dr. Wisnu, you have presentation you have get 3 formula from network for DM. Is right?
Actually, the three combination.
Yeah, 3 combination. Okay.
Yes.
And if I see the composition is very different from if we compare combination in jamu, OHT, or phytopharmaca. What about do you opinion about it? Because it's very different, and some of component maybe I don't know, like mango leaf. Is it not used in jamu?
Yes,
Okay.
actually, my approach is depend on the data, because we collect the data from the knapsacks and also the others database. For example, IJA Analytics developed by APB University. So if the data actually is not complete or not covered many maybe in the common plans for diabetic, so maybe the results also biased maybe. So this is actually depend on the data, because the research actually conducted by poor computer scientists. So we cannot we just propose the method. So the main objective is propose the result. Propose the method, not the result. So maybe we will continue to, for example, make a collaboration with the others researchers, especially for pharmacology or maybe medicines, to collect the more accurate data, like that. In my paper, actually, the analysis also focus on the performance algorithms, not the results. But we also show the result maybe as for discussing or something like that.
Okay, thank you, Dr. Wisnu. And I have also one question for Morimoto Sensei.
Yes.
It is if we make curcumin injection. So, what do your opinion if we use the parenteral injection to overcome the lower bioavailability of curcumin?
Yeah, that's a very important point, I think. We use a hardware model using this strategy, but we use COPD patient or diabetic patients, and also the need patient who are addicted to this DDS-curcumin clinical setting. So there is some report regarding this DDS-curcumin. So I think that in the future we'd like to the more bigger large-scale clinical trial I would like to try. Thank you very much.
Okay, Thank you, Prof. Due to the limitation of time, maybe it's the last question. Thank you for all participants and all speaker. Very, very interesting and good information, not only for participants, also for me. Thank you.
Thank you. Terima kasih. Thank you.
And also for Dr. Wisnu, and I finish this session. Thank you very much.
Thank you very much, Prof. Moon Im. Thank you, Dr. Morimoto Sensei. Thank you, Wisnu.
Thank you.
All right. Thank you very much for a very insightful session, Professor Abdul Munim, Dr. Wisnu Ananta, Professor Tatsuya Morimoto, and Professor Wawai Mulia Arozal. Up next, we will have break time for about 3 minutes before we begin the next session. So break time session begin. We will come back in 15 and 10. All right, welcome back to all participants. Our next agenda will be Symposium 9. The theme of this session is Big Data Analysis in Metabolic, Cardiovascular, and Aging. This session will be directed by Dr. Eric Daniel Tenda as the moderator. First of all, I would like to introduce Dr. Eric by reading his CV. Dr. Eric Daniel Tenda is the head of Artificial Intelligence and Digital Health Research Group, Cluster Medical Technology, Indonesian Medical Education and Research Institute. He is also consultant, interventional pulmonology, in internal medicine specialist, Division of Respirology and Critical Care, Department of Internal Medicine, Dr. Cipto Mangunkusumo National General Hospital, Faculty of Medicine, University of Indonesia. So without further ado, I would like to offer the time to Dr. Eric. Good afternoon, Dr. Eric. We are very happy to have you here.
Thank you for having me. Thank you.
All right, so Dr. Eric, the time is yours.
All right, thank you. Sorry, let me switch my screen. All right, good afternoon, everyone. So this is a lovely Sunday.
And it's actually a great privilege for me to be a chair for the second last sessions for today symposium. So as mentioned on the schedule, we are going to have a discussion, a fruitful discussion about big data analysis in metabolic and cardiovascular and also aging. So we will have 3 speakers for today. And so without further ado, again, let me welcome the first speaker, Dr. Joris Deland, who will discuss or explore about identifications of metabolic biomarkers to estimate vulnerability and mortality in older adults. So Dr. Joris, time is yours.
Thanks a lot for the introduction. So I will now share my screen. And for the, of course, first of all, thanks to the organizers for the kind invitation for the symposium. So good afternoon to everybody here. It's still morning. It's 9 o'clock here in Germany. And today I want to talk a bit about the work that I've been doing. First of all, during my time as a PhD and postdoc in the Leiden University Medical Center in Leiden, and then the continuation of this during my time in Germany. So I'm actually working at the Max Planck Institute for Biology of Aging, which is located in Cologne, in Germany. So I want to start off with this graph of how we see that human life expectancy has been increasing the last 200 years. So here's the example data from the Netherlands, where you can see data for men and women from different birth cohorts from the 1950s, 1900s, and 1850s. And as you can see here, you see that the curve is nicely shifting to the right, which means that we are getting older over different generations. However, this increase in life expectancy has not been accompanied by a similar increase in healthy lifespan. So the number of years spent in good health before the occurrence of the first chronic diseases. So we really need to spend some work on identifying markers that can actually help us to not only live longer, but actually to live longer for healthier. And in the field of aging, there's this famous concept of the hallmark. So there are different processes that people consider as kind of most important processes in aging, which are indicated over here. I will not go into detail, but and then there are different ways in which we can target these different hallmarks of aging. So we can do specific interventions and challenges. And the idea is that by targeting these specific hallmarks, that may lead to actually a positive effect on age-related phenotypes and diseases. And these are very broad. So it can be things like loss of bone mass or muscle mass. It can be something to do with fat. It can be multimorbidity, and it can be frailty. So the idea is that by influencing all these markers or some of these markers of aging at once, we might be able to prevent a lot of different things happening with increased age. And for this purpose of this talk today, I will focus on the metabolites. So what the research we have done on metabolites in their relation to aging. So for this, we use the so-called Nightingale Health Platform. So this is a platform which is NMR based. So this is a specific type of measurement that you can do. It's very standardized and high throughput, which means that you can just send a sample wherever it comes from, and the measurements are always standardized, and it's very quantitative. So the thing is, you can actually get the information of the different metabolites in a quantitative way, which is normally always a bit of an issue when you do metabolomics, that or people go for this more untargeted, but then you have the disadvantage that you cannot really have quantitative measurements, or they go for this quantitative approaches, but of course then you can measure less because you really need to have good standards for that. So in total with this platform you can measure about 226 markers. A lot of those are derivatives from each other. So if you actually look at the list of markers that you measure singly, that's not so many, but still it's a decent amount, around 70 markers. And these markers are related to things like ketone bodies, like glycolysis related metabolites. They have a metabolite related to inflammation, and a lot of fatty acids and cholesterol metabolism. This is one of the main things in this platform. There's a lot of things related to cholesterol and also fatty acids. And this platform has already been widely used in epidemiological studies. So, for example, it has been used to identify metabolites involved in diabetes, in cardiovascular disease, and in neurological diseases. And also this platform has now been measured, for example, in the UK Biobank, which is one of the biggest biobanks in the world, which contains around 500,000 individuals. So it's really widely used now in epidemiological studies. And in the Netherlands, we actually in Leiden, so this is was coordinated by Marjan Beekman at the Leiden University Medical Center. We actually set up this BBMRI Metabolomics Consortium. And the idea was that we would measure this metabolomic platform in many different studies at the same time, and then do all kind of analysis with different outcomes. So in total, we measured in 25,000 individuals, and we looked at type 2 diabetes, osteoarthritis, cardiovascular disease, and all kinds of other things. And there are already many papers published based on the results from this. But today I would like to focus on the part that I was involved in, which is the part on aging and mortality. And this was actually set up, also the BBMRI in general was set up by Eline Slagboom, who's also a professor at the Leiden University Medical Center. I started this project when I was still a postdoc in her group. And the idea was that, okay, what we want to do with this Nightingale metabolomics platform is to create different types of so-called metabolomic scores, which can say something about somebody's biological age. I'll come back to that in a second. But also we want to see, okay, can we maybe predict mortality or age-related morbidity using this platform? So if we go to the biological age, why are we interested in defining biological age? Well, the idea is that somebody has a chronological age, so that is the age that it has in the passport. But the idea is that some people are older than their chronological age, while other people are younger than their chronological age. And this biological age, we think, is more representative of the health status of an individual. It can then potentially also be used in other types of studies to predict kind of if somebody will develop a disease. So if a person has a low biological age, that might be positive, and he has less chances of developing disease, while people that have a high biological age, we should definitely treat and try to prevent them from getting a certain disease. And we also want to kind of see if we have such biomarkers of aging, can we also use them in model organisms and make kind of a comparison between things we see in model organisms and things we see in humans. So the most famous example of so-called biological age predictors are the epigenetic predictors, which were developed by Steve Horvath. And the idea is that if you look at the chronological age and you take a measurement, in this case it's the methylation, and you then predict kind of, you look for markers that are very well predicting chronological age. Based on your methylation, you can get kind of your methylation age. So the algorithms are designed to predict chronological age. So they use the methylation markers that they have, and they try to predict chronological age as good as possible. And after they've predicted that, they see actually that there's a deviation. So some of these individuals will have a lower biological age as expected. So these are the blue ones, and some have a higher biological age than expected based on their chronological age. And with this deviation, you can actually then do analysis and see if this deviation is then predictive of outcomes. It's not ideal, I will not go into detail today, but basing it on chronological age is likely not the best outcome to use. So that's why we also do it differently later, which I come back to in a minute. But we also decided to do this first with the metabolomics. So this was work by Dr. Erik van den Ecker, which is also working at the Leiden University Medical Center, where we try to predict first your chronological age based on your metabolites. And when you do that, you see that you can nicely predict it. It's not a perfect prediction. So with methylation, you get to 0.9, which is very, very high, 0.99 even, which is very high. With metabolomics, the R-squared is about 0.4, which is much lower, but still it's pretty good in predicting your chronological age. And then we actually look at this deviation from this prediction. So the individuals that are indicated over here, you actually measure kind of their age based on the metabolomics, and you subtract from that the age. And you subtract from that the age based on their chronological age, and then you get this delta which we then called Metabo-Age. And with this, we do then the predictions. And the predictions that we did were, first of all, okay, is it associated with mortality? And that indeed seems to be the case. So if you take this difference between your chronological and your biological age, it's actually predictive of mortality. So the lower your biological age, the less likely it is that you will die. And you also see that the effect is not only for all-cause mortality, but it's for also mainly here for cardiovascular mortality. So we think that this predictor that Eric has created is very predictive of cardiovascular disease. And it's also quite similar to the things that have been published on this epigenetic age. So this metabolomic predictor has a similar effect as this epigenetic predictor. However, we thought, okay, this is not the best predictor we want to use. We want to come up with something better, which is maybe based on a more interesting outcome than just age. And one idea that we got is, okay, let's look then at mortality. So we take mortality as the outcome and then see if we can find metabolites that are predictive of mortality. And then the goal is not to create a predictor where we have somebody coming to us and say, okay, we now know how old you will get. This is not the goal we have. The goal is to identify the vulnerable people in the society. So we want to use it to generate kind of a predictor. If somebody comes to the clinic and say, okay, you have an increased risk now of dying. So we want to now start a treatment so that we can still prevent it. So we don't want to sell it as kind of, we know how old you can get. We really want to use it more in a clinical setting. And the idea is indeed then to come up with the lifestyle interventions or other kind of treatment, which could then help you getting in better level of the score, so that you can then have less likely risk of dying in the future. So there were already some studies done on the effect of metabolites on mortality, and this is the study from Christa Fischer et al., which also used the same platform as we used, but in much less individuals than we did in the end. And they identify already 4 biomarkers over here. So this is a immune-related biomarker. And then they have albumin, VLDL particle size, and citrate. And these 4 markers were predictive. It's already quite predictive for mortality. But we then decided to take it to the next level, and we expanded this analysis massively. So in total, we then analyzed around 45,000 individuals, which came from 12 different cohorts, which are mentioned over here. And during the time, so we collected blood samples, and then we wait till these individuals die. And then we actually look back in these samples that we collected, if we can identify metabolites that are predictive of when these people died. And around 5,500 of this 45,000 individuals that we included died during the follow-up. The limitation that we directly have to mention here is that this was only done in European individuals. So there's not yet so much data available from individuals of other ethnicities, which is something we should definitely work on. But this study was really focused on people from European descent. And when we did that, the first thing we saw is that many of these single metabolites associate with mortality. So if you do a single analysis of each metabolite with mortality in our study, most of them actually associate with mortality. And then we thought, okay, what can we do to see which of these are independent from each other? So we really wanted to identify the metabolites that are independently from each other associated with mortality. And when we did this, we ended up with 14 different biomarkers that actually were independently associated with mortality in this study. And these markers are indicated over here. So we have, for example, lipid-related things like this total lipids in chylomicrons and extremely large VLDL particles. And in small HDL, we have also the diameter of VLDL particles. And this is not a surprise. Like I said, this platform has a lot of lipid-related things, so it's not surprising that we find this. But it also has some other interesting things like glucose levels and several amino acids. And the amino acids we were most interested in here are the branched chain amino acids, because you have both isoleucine, leucine, and valine showing an effect. And what you would expect actually is that all these 3 amino acids would show an effect in the same direction. And if you look at the single metabolite level, that's also the case. However, if you combine them together in one model, you actually see that the effect switches for isoleucine. So instead of having the effect that the increase in the metabolite is associated with a decreased risk of dying, like it's the case for leucine and valine, it actually is the opposite. So if you have an increased level of isoleucine corrected for valine and leucine, it actually shows a detrimental effect. So that is also interesting to see that if you can include all these metabolites in one model, you see also that things start changing. So it's definitely important to do that. So what we then also saw is that if we look at this association with mortality, we actually see that this association is different, is the same for most types of mortality. So we have it for cardiovascular mortality, and also for immune-related mortality. All these metabolites that we identify, most of them associate with all these types of mortality. There are some specific ones like glucose, which specifically associate with cardiovascular mortality, but the majority of them actually seems to be general markers of mortality. And if we also, and then we decided, okay, if we make now a score out of these 14 biomarkers, so if we combine them into one score, how does that then look in our different populations? And we nicely see that this biomarker score is then, as expected, associated with mortality in all our cohorts, where you have, if you have an increased score, you have actually an increased risk of dying due to mortality. And then if you look at different age strata, which is also quite interesting, you see that this effect is actually quite the same among these different age strata. So it doesn't really matter if you're below 60 or over 90 years of age, the score is still predictive of your mortality. And this is quite interesting because normally we know that there are these specific factors such as triglyceride, where that's actually not the case, that the effect is, for example, in this case, results in an increased mortality risk. A higher level results in an increased mortality risk if you're young. A decreased mortality risk if you're young, but an increased mortality risk if you're old. And this was always a tricky thing when we look at biomarkers of aging, that often we see that these biomarkers work very well before the age of, say, 85, but afterwards they don't work so well anymore. But in this case, the score that we created actually works across all age strata, so also even in these very highly aged individuals. So we then try to see, okay, is this score also, can it improve the prediction accuracy compared to conventional risk factors? So we already have conventional risk factors in the clinic that people use to predict mortality, which are mentioned over here. And the idea was, okay, can these 14 biomarkers predict better mortality, or at least equally? And what we actually see was that was indeed the case. So the red here indicates the effect of the 14 metabolomic biomarkers, while the black here represents the conventional risk factors. And what you want to see is actually that this curve moves here into the left corner. The more it moves to the left corner, the better it predicts actually the outcome. And what we see is that the prediction, which can be between 0 and 1, if it's around 0.5, it says that it's as good as just random. So you want to have it as closely to 1. And what we actually see is if we take, for example, 5-year mortality across all ages, we see that these conventional risk factors have a C-statistics of 0.77, while the metabolomic biomarkers have a prediction accuracy of 0.83. So we actually, just with these 40 metabolites, just this one measurement, we actually already outperform the conventional risk factors. We also try to combine them then into one model, so the conventional risk factors and the metabolomic biomarkers, but this didn't improve the prediction any further. So you can also, of course, also look at age-related morbidity instead of mortality, and this is also what others have been doing. And this is an example of that, where people try to create this kind of scores for specific disease outcomes. In this case, it was severe pneumonia. So this paper was published around 2 years ago in the time of COVID, where they actually, the company itself, so the company Nightingale, was trying to identify a predictor of pneumonia. And actually, they also created a score for that and showed that this score could be used to predict this. Interestingly, they also looked at our metabolomics mortality score in this study, which they didn't publish in the end, but we know they did it. And actually, the metabolomics mortality score, which we now call Metabo Health, shows also an equal effect on COVID-19. So their score, which was was specifically designed for the outcome of inflammation of infectious disease, works equally well as our score, which was designed for mortality. So this shows that our score can actually also be used to predict other kind of outcomes than just mortality. So the conclusions from the work that we did is that we created a biological age marker, which is called metabolic age, which is a good predictor, I would say, of cardiometabolic disease and mortality. However, we then also tried to design another kind of biomarker score, which we call now metabolic health, which consists of these 14 biomarkers, which are all independently associated with mortality. And this score is even better in predicting mortality, which is not a surprise because it's also created on mortality. But it seems it's also better in predicting all other kinds of outcomes. So this biological age predictor can predict some of these outcomes pretty well, but kind of in all the analysis that we're doing so far, we see that this the metabolic health score outperforms the metabolic age score. So it shows that if you take an outcome that is more indicative of something that we are actually interested in, namely mortality or morbidity, it outperforms things that are based on chronological age. So what we now want to do is actually see, okay, what kind of vulnerability this metabolic health score reflects. So what does it associate with? What kind of things? And there are already several studies ongoing now. And this is one example where actually people that were looking in the clinic at the risk of mortality of individuals that actually broke their femoral fracture. So this patient came into the clinic, and then they measured the metabolic health score and looked, okay, how well does this predict mortality in these individuals? And actually, you can see here, if you make tertiles of the score, it actually indeed also predicts mortality in this patient. So this is a very specific population, but even there, it predicts mortality very nicely, where the higher the score, the more likely it is that you will die during follow-up. We also want to see, okay, how well does it work in comparison to other kind of predictors that are based on other kinds of measurements, like epigenetics, for example. So one of these epigenetic scores for mortality is GRIM-Age, and we actually now trying to see, okay, is our metabolic health score doing similar things to GRIM-Age, or does it do something different? And if so, are they showing the same effect? So can you kind of should you combine them together, or should you only use one of them? And what we actually see, this is very preliminary data. It's from the people from Rotterdam that actually looked at this. In the same population, they looked at this metabolic health score and this GRIM-Age score. And what they actually see, if they combine them into one model, they actually see that they are both still predictive of mortality. So you combine them together and they both show an association with mortality, which shows that they're independently doing something with mortality, and they should actually be combined into one study, which is also what we expect. We expect that our metabolic health score is not yet complete, and there are many other things that we could add to even better predict mortality. And this is also shown here now by including this epigenetics, that even further increases the association with mortality. And then there are several other things we are currently doing, such as looking at the heritability of the metabolic health score to see, okay, how much of this is actually heritable and how much of it is environmental. We want to see kind of if we do specific kind of interventions in people, how does that influence this metabolic health score? And what I'm mostly working on at the moment in Cologne is actually determine if we can bring this metabolic health score to the clinic. So we have several ongoing clinical studies in Cologne, and now we are including the measurement of the metabolic health score to see if this can help to identify the vulnerable people in the clinic. So with this, I'm coming to the end, but not before thanking many people, especially Eileen Slagboom, which was kind of the founder of all this research. And I continue working on it while I'm in Cologne, and she's doing the same while in Leiden. So we're still collaborating a lot of this to really dive deeper into what we can do with this metabolic health score. And then there's all these other people that I want to thank that were actually involved also in this large study in which we identified the metabolic health score. Thank you for your attention.
Thank you very much, Dr. George. I think that's a very interesting result that you already published. I'm looking more for discussion about the metabolomics that you presented on your presentation. But before we get back to you again, so I would like to invite our second speaker for this session, Dr. Shun Kosaka. So again, apologies, Joris. I'm supposed to introduce you first before I give you the time for your presentation, but I will not forget this one. So let me introduce the second speaker, Dr. Shun Kosaka, affiliated with Department of Internal Medicine, Cardiology at KU University. His formal education is a medical doctor in the same university, internist cardiology in Columbia University, USA. Fellowship in Cardiology, Texas Heart Institute, Baylor College of Medicine, USA. He got lots of professional activities. He is now a senior assistant professor at Department of Internal Medicine, KU University Graduate School of Medicine, also an adjunct associate research scientist, divisions of cardiology at Columbia University. So without any further ado, let me welcome Dr. Kosaka.
All right. Thank you so much for a kind introduction.
Thank you.
My name is Shun Kosaka. I will be talking about the role of regional and national registries and how that activity kind of led to improvement in the quality of care and outcomes for cardiovascular disease. My focus will mainly be on coronary heart disease and the heart failure registries. So let me share my slides here. Here are my disclosures. So I would like to start my talk with the percutaneous coronary intervention registries. And this is a lesion in the proximal LAD, so-called widowmaker. And for this type of lesion, the various improvement in percutaneous interventions, Forsman's catheters, zones, coronary angiogram, and Dr. Gunsig and Dr. Fabaroro had generated the coronary revascularizations, and we're now at the era of the percutaneous coronary intervention performed in perhaps more than half the patients with a significant coronary heart disease. This is sort of like an animated scheme of the balloon angioplasty in the old times, with coming in with the stent, and the number of percutaneous coronary intervention and coronary artery bypass has really expanded in Japan ever since its introduction, and of the particular note, the PCI. But the role of the registry is, how to think about how we could put this procedure further into the better patient care. And one of the issues that we had with the percutaneous coronary intervention is development of the acute kidney injuries, the so-called AKI. With the AKI issue, we first tackled this problem with the regional registries. The regional registry that we had for the percutaneous coronary intervention is KICS PCI. This is the short name version of the KO Inter-Hospital Cardiovascular Studies. We had 15 network hospitals that treats the patient with the percutaneous coronary interventions, and we had the trained CRCs, and we collected the data in collaboration with the national database and try to provide the feedback for practicing cardiologists. We have been, this has been an ongoing registry since 2008. And one of the models that we tackled on was using the statistical models on incorporating these important variables and helping to predict these adverse events for the practicing cardiologists. And we know that better prediction, would certainly help the physicians with providing better care. The classic work from the United States, including the group from John Spertus, has shown that showing the prediction value for these adverse events can actually improve or lower the rate of the complication rates. But the issue that we had in Japan was that, yes, we have a lot of prediction models coming from Europe and the countries in the European countries in the United States, but we were not sure whether these prediction models will apply directly onto our patients in Japan. So in collaboration with the US NCDR acute kidney injury prediction model, we tested their model on our actual Japanese patients. And as you can see, it did reasonably well, but you can see that the dots will sort of like fall out towards as the risk starts to rise. So it was a significant problem. And what we did was we recalibrated the prediction model with, we did not change the slope, but we changed the beta intercept. And then we saw the numbers actually fit well. Look at the red dots that's plotted on this calibration plot. And then it fits much better than the blue plots that with the original, the US NCDR AKI registry. So we speculated that this calibration or this gap in this predictive model is probably due to the threshold for initiating the hemodialysis. Because I did my residency training and fellowship training in the United States, and then I came back to Japan to do actual cardiology practice, and I've noticed that the initiation of this hemodialysis, the threshold is much lower in Japan compared to the United States. Now, I'm not really going into like whether this is good or bad, but it's just different. So the models needs to be changed accordingly. Here is the calibration plot, and we see that the calibration plot matches fairly well with the actual instance of AKI or initiation of the hemodialysis. The other complication that we tackled with is the bleeding issue. The bleeding is really a big challenge for us who treat the patients in East Asia, because this is one of the white paper that was published in Circulation back in 2019. And as you can see on the bottom part of this slide, they quote that lower dose of antithrombotic regimens are recommended in Asian patients because there is a greater bleeding concerns in Asians, particularly the East Asians. So, and this is another review article that was published in Nature Review Cardiology back in 2014. And they're saying that the sweet spot for the bleeding versus thrombosis is actually a little bit towards the safety margin. The safety margin of the bleeding is a little bit towards the right on the East Asian patients. So we, as you know, we use a lot of antiplatelet agents, antithrombotic agents, but that needs to be lowered a bit for the Eastern patients is what they are suggesting. So we've been very successful with the AKI model, but not so in the bleeding models. This is one of the preliminary work that we did for prediction of the bleeding. And as you can see, the blue dot, blue bar showing the actual bleeding rate, it surpassed the predicted bleeding rate in almost all of the risk group patients. So this has become really a challenge for us, and we have not overcome this challenge yet. We haven't created a reasonable model like for the AKI in Eastern patients. But what we did see was that the AKI and bleeding is actually closely correlated. One of the studies that we did back in 2013 showed, this is also a work from the registry, showing that the procedural bleeding or even the lowering of the hematocrit is actually very well correlated with the development of the AKI, the contrast in this AKI, so to say. So there's a close interaction between these two complications related to PCI, but again, this is a hint towards getting a better prediction, but we haven't achieved that goal just yet. Now, I'm going to shift gears a little bit and talk about national registries. The regional registries were really good in getting these numbers, prediction models, and going further into the pathophysiology of the percutaneous coronary intervention related complications. What we did with the National Registry is we used it for better patient selection, more towards like how the policy could be changed or the guideline recommendation could be changed in our country. The National Registry in Japan has become a focus ever since like 2008 or 2009, because this is the map of United States overlapped with the map of Japan. And actually, in the United States, the core centers for cardiovascular problems, mainly the tertiary care centers for cardiac care unit, is really not that many. We have a few in Chicago, St. Louis, maybe some in Arkansas and Dallas, Houston. But that's not the case in Japan. If we map all of the tertiary care centers in Japan, the stars would come like this. So we have like a small mid-sized level PCI institutions in Japan, and this is mainly due to the Japanese policy where we have a nationwide coverage for the insurance system, and the government would really like to have equal access for all of the Japanese populations, no matter where you live. So this is little different, or much different from the policy that you have in that people have in the United States. So given those differences, we were very interested in how PCI is practiced in this this like multiple institutes. So we launched this CVIT registry where it's built in, and with the smaller number of variables, maybe like 20 to 25, easy to register, but covers the whole country. So this actually was launched in 2010, but they started the registration system in 2013. First scientific manuscript was published in 2015, and first federal funding was obtained in 2016. And the initial thing that we were interested in, this is a paper or the chart that's derived from the COURAGE trial. And this COURAGE trial was shocking for us because the percutaneous coronary intervention didn't actually show the mortality benefit in patients who are at low risk. And we saw the similar finding and later on with the ischemia trial. But again, we were kind of wondering how we were doing with the Japanese practice. And this is one of the early studies that we did. And we saw that the majority of the differences were between US and Japan was coming from how we tackle the patients with non-proximal LAD patients. In Japan, non-proximal LAD patients were, we saw the stenosis, but they, frequently the ischemic evaluation was not performed in this patient, where it was mandated in countries like United States or European area. So that was sort of like a major problem. And then in 2020, we further tackle this issue where, when we compare the actual nationwide registries between Japan and the United States, how would that stand out? And this is sort of like the chart that we are seeing. Note that the y-axis, the number on the y-axis, is a little bit different between the United States and Japan. In the United States, between 2013 and 2017, we're seeing that over 2/3 of the patients are coming in with acute coronary syndromes, whereas in Japan, about 75% of the patients are elective. So and the number of the ACS patients are relatively small. So it's very important for us in Japan to sort of like consider the actual or the guideline recommended ischemic test, because we have a lot of elective cases. And the focus was like how the pre-testing was performed in this era. And in the United States, we see that almost none of these patients are coming with the CT angiogram. A lot of patients get stress tests, and some patients, probably because of their symptoms are so significant, they come in with no assessment. In Japan, what we saw for 2016 and 2017 is that a lot of patients actually coming with the CT angiogram. So that's probably one of the differences that we're seeing. But please also note that a majority of the patients are coming in with no assessment. So we concluded that this probably needs a lot of work. We have a lot of elective cases, and we're not doing much of a ischemic evaluation. So this is the guidelines that's been published over the last 5 years, and we've been trying to get into this discussion. But again, this is one of the work of the registry, how we have used the registry to meet the evidence practice gaps and implement the discussions when we generate these guidelines. The last part of the talk is how these registry can improve the practice itself. And I'm going to shift gears once again and talk more on the heart failure registries. And the heart failure has evolved rapidly over the last 5 to 10 years. In 2017, the guidelines from the United States had a couple of medical interventions or new agents that would further improve the patients with heart failure. And the meta-analysis have really shown that these heart failure medications can improve the patient's outcome. But the major issue with the heart failure, unlike the PCI, is that, yes, there's a lot of options, but these guideline recommendations are really, really complicated. For instance, for the recommendations for the ACE-ARB, yes, we should start ACE-ARB on these patients, but there are so many details on this initiating of the ACE-ARB. Did you check the kidney function? Did you check the blood pressure? Are there any other contraindications? For this certain scenario, we should do this. For the others, we should do this. Titration, weaning. So it's really complicated. So on the contrary to the coronary artery disease, we have a lot of options with the medical therapy, but it's really hard to get that into the actual practice was the major issue in heart failure. So we or the other folks have developed the performance and quality measures, and these were termed the vehicles to accelerate transition of these very difficult scientific evidence onto the clinical practice. And the role of the registries for implementing these performance measures or the quality the indicators is to look at the existing gaps in care once again. And one of the studies that we did in collaboration with the folks in the United States is after the implementation of ARNI, the sacubitril/valsartan, in the United States, it was introduced in late 2015. The blue line shows the implementation of ARNI amongst the heart failure patients. And we see that it's going in about 14% of the patients at this point at 2019, which is probably not enough. And the major problem is the other medications like beta blocker, ACE-ARBs, and MRAs, they're like flat parallel. So that has not improved as well. We also did similar study in Japan actually last year, and we analyzed the heart failure registry in Japan and noticed that we extracted the patient that would meet the guidelines for inclusion criteria for like trials like Paradigm or DAPA and the SHIFT, and we're also seeing the similar things. The implementation rate of the important classic heart failure medications are 74% for ACE-ARB. Beta blocker is actually a little bit better, 84 to 87%. MRA is like lags far behind, like 47% or less than 50%. So we still see these like practice gaps. And we have had multiple discussions with the folks in the United States and the European countries. And a lot of authorities would say that, in Japan, you guys have like universal health coverage. You guys just have to deal with the government. And so it seems so easy. Whereas in the United States and Europe, you have like multiple stakeholders for insurance, what's and forth. But it's actually not that easy. And the last example that I would like to share with you is there's always a risk of unintended consequences when we put in these like guideline recommendations or performance index or the quality indicators. This is actually related to the door-to-balloon time for PCI patients. We all know that door-to-balloon time for PCI patients less than 90 minutes has been shown to be prognostically favorable for patients with the ST elevation MI. And in Japan, in 2014, under this universal healthcare insurance system, the government decided to provide an additional hospital incentive of approximately $3,500 $100 when patient with the positive biomarkers achieved door-to-balloon time of 90 minutes or less. So we wanted to see what would happen with this new rule, and we used the clinical registries. And after implementation of this reimbursement policy, yes, we did see some improvement in door-to-balloon time, but there were some unintended consequences. So what was that? So this is the patient of ST elevation MI. And after the change in the reimbursement policy, we saw that the portion of the patient that met the door-to-balloon time less than 90 minutes had increased, but more so in low-risk patients. So yes, but that's not quite. The major issue that we had over here was that since the criteria for the myocardial infarction, acute myocardial infarction, was biomarker related, not EKG related. I don't know who put those rules, but it was set in stone that this was the rule. So that also improved the achievement of door-to-balloon time for NSTEMI patients, which is not recommended in the guidelines. So we see, and we also saw that the low-risk patients of the non-STEMI patients were actually the highest number of the achievement for the door-to-balloon time. Again, this is not recommended in the guidelines. They actually suggest conservative approach for these patients. So, and as a consequence, the bar on the lower part of this chart, that's the observed mortality and expected mortality. That hasn't really changed a bit since the implementation of the implementation of the rule. So this is really, I would say this is unintended consequences. So with this, I hope that I've been able to show you some successful, some work in the progress, but successful use of the regional and national registries. But there are some pros and cons on the use of this large data or big scale data. But the message falls down to, like, the practice, you're trying to do your best, but if you don't measure it, under these nomenclature type of variables, you won't know like where to make the progress and where the gaps are. So that's actually where the registry or the big data kind of like fits into the practice. And I hope, we'll continue to improve, help improve the actual cardiovascular practice with these tools. But I think we can do much more with the collaboration from other countries, or, we're not the only one that's kind of, unique amongst the Asian countries. So I think there should be a lot of studies coming out from this area. Lastly, but not least, I would like to thank all of the collaborators. We have Japanese collaborators and the US collaborators and the postdoctoral fellows that's assisted in this research. Thank you so much for your opportunity.
Thank you, Dr. Kosaka. That's a very excellent presentations. I hope everyone seen your presentation. I mean, I totally agree with you. If we don't measure it, we don't know where to actually improve the services, correct? So I will get back to you again for the discussion. But last but not least, I'm happy to welcome this my dear friend, who will be the last speaker for this session, Dr. Fatima Sigit, MD, PhD. So without any further ado, Fatima, time is yours.
Thank you very much for the opportunity, Dr. Eric. I would like to share my screen first.
Sure.
I hope you guys can see my screen now.
Very clear.
Okay. I guess I would like to say, first of all, good evening to those of you who are joining us from Indonesia and from Japan. And also good afternoon for those of you who are joining us from the Netherlands. And of course, from Germany, Dr. Dalen. It is an honor for me to speak alongside with Dr. Dalen and Dr. Kosaka. Thank you very much, doctors, for your wonderful presentations. And my name is Fatima Sulistiawati Sigit. I am an assistant professor at the Faculty of Public Health, the University of Indonesia, and I'm also a senior researcher at the Metabolic, Cardiovascular, and Aging Research Cluster at IMERI, Faculty of Medicine, University of Indonesia. I give my presentation today a title of Ethnic Differences in Adiposity and Metabolic Syndrome. And my work here is the results from population-based studies of the Dutch and Indonesian populations. So to provide a general background of my studies, I would like to begin with a well-known fact that within the same amount of adipose tissue, or let's say the same level of BMI or body mass index, the Asian population are known to develop cardiometabolic complication earlier than the Western population. In fact, because of this very reason, the cutoffs for obesity, be it overall obesity and also abdominal obesity, were lower in the Asian population than the Western population. It is still poorly understood why this discrepancy between populations exists, but one of the most important hypotheses that might explain the increased cardiometabolic risk in the Asian population is the lipid overflow hypothesis. In this hypothesis, they propose that the Asian population has a smaller subcutaneous fat compartment, so that when obesity develops, what happens is the excess lipid overflows earlier to the visceral compartment. So a bit to refresh our memory in what and where is subcutaneous fat and visceral fat, I would like to show you this illustration. Dr. Eric, can you help me indicating if you can see my pointer or not?
Yes.
Yeah, okay. So this is our belly, and the subcutaneous fat is the outer part of fat compartment that is located directly beneath our skin. So the subcutaneous fat over here is the primary storing site for excess fat in any case of positive energy balance. And what happened is if the positive energy balance continue to occur, this compartment, the subcutaneous fat compartment, can no longer hold the excess fat, and the lipid overflows to the deeper, more profundal visceral fat compartment. And this is when the cardiometabolic complications start to occur, because studies have shown that accumulation of fat in the visceral compartment is strongly linked to insulin resistance and subclinical atherosclerosis, that is a precursor for type 2 diabetes and cardiovascular diseases. And also, if we look deeper into a more metabolic and hormonal activities of the body fat tissue, it is known already that the adipose tissue releases some hormones, with the two major hormones being the leptin and adiponectin. And those two hormones, the leptin and adiponectin, have opposite associations toward each other in regard to glucose and lipid metabolism. And it is also known that in obesity, what happened is the secretion of leptin is increased, but the adiponectin secretion is decreased. However, it is still not much known whether the secretion of leptin and adiponectin were different in the two populations, the Asian and the Western population, and whether the two hormones associated differently to the different risk of metabolic syndrome in the two populations. So the umbrella topic of my research is to contribute to the literature in explaining the why question. So why does the Asian population have an increased cardiometabolic risk? And we are actually grateful to be obtaining access to these three big data sets that is representing the Asian, Indonesian, and the Western Dutch population. So the first one is the NEO study, which is the Netherlands epidemiology of obesity study conducted in the Netherlands. And the second one is the sugar spin study. And the third one is the Indonesian National Health Survey. But in particular, I would like to share you all today the results of our studies that has been published that is answering these two more detailed research questions. So the first research question that I would like to share today is, because we want to confirm the lipid overflow hypothesis, we investigated whether a different body fat distribution represented as the overall and abdominal obesity. Sorry, I think I hear some.
Alright. I think dari panitia mungkin bisa off partisipan yang masih. Okay, alright. All right, I think Dr. Fatima, you can continue.
Okay. Thank you. Just let me know if you have any question. Just feel free to interrupt me. Yeah. So the first research question is, we would like to know whether a different body fat distribution in the two population as represented with overall and abdominal obesity in the two population relates to a different risk of metabolic syndrome. And the second research question that we wanted to investigate is, we want to know the secretion of the two hormones in the two populations and whether the two hormones, the leptin and adiponectin, associated differently to the risk of metabolic syndrome. And to answer this research question, we analyzed the data from the three big studies. I've mentioned the three studies. The first one is the NEO study, and I would like to hear giving a short introduction, a short description of each studies. So the NEO studies, or the Netherland Epidemiology of Obesity study, is a prospective cohort study, a population-based cohort study that is aimed to investigate pathways that led to obesity-related diseases. So the NEO study is conducted in Leiden, the Netherlands, and it included around 6,600 individuals aged 45 to 65 with an upper sample of individuals with overweight and obesity. And then the second study, it is a completely different study. The sugar spoon study is a double-blind randomized clinical trial that is aimed to investigate the effect of anti-helminthic treatment to insulin-resistant and cardiometabolic health. The sugar spoon study is conducted in Flores, which is a rural area in Indonesia, and it included around 1,700 participants aged 18 years and above. And because this is an RCT, we only included the data from the baseline measurement of the sugar spoon study. And we did this to make sure that any intervention were not commenced before. And the last data set that we use in our analysis is the Indonesian National Health Survey study, which is a periodic routine survey conducted by the government of Indonesia, particularly the Ministry of Health. And this study is aimed to screen for the presence of infectious as well as non-infectious diseases, as well as to monitor the health status of the Indonesian citizen in general. And this study involved a multi-stage systematic random sampling and also probability proportional to size method to ensure that each element of the population from the 34 provinces in Indonesia were sampled, and also taking into account the differences in urban and rural distribution, as well as the differences in the geographical densities. And out of 1 million participants that is sampled in the National Health Survey, among 30,000 of them were randomly selected to undergo a blood lipid and glucose measurement. And we define the cardiometabolic risk as the metabolic syndrome, which is a cluster of at least 3 out of 5 cardiometabolic abnormalities as listed here in the table. And we use the criteria from the joint interim statement criteria to diagnose the metabolic syndrome. To analyze our data, we did a weighted analysis in the NEO study and the Indonesian National Health Survey study. This is to correct for the oversampling of individuals with overweight in the NEO study, and also to correct for differences in the geographical densities and also urban-rural distribution in the Indonesian National Health Survey, and also to examine the association between the exposure and the outcome in our studies. We did a multivariable logistic regression analysis, with the exposure being the BMI and waist circumference for the first study, and the leptin and adiponectin for the second study, and the exposure being the metabolic syndrome and its component. And we did the analysis as stratified by sex and by population. And for the second study, we also did the analysis stratified by BMI categories. And we also corrected the associations for confounding factors such as age, education, smoking and alcohol, pre-existing diseases, family history of diseases, and a proxy of socioeconomic status. And moving on to the result, here I would like to show you first the result from the first study, which is to investigate whether a different body fat distribution between the two populations relates to a different risk of metabolic syndrome. And this is a cross-sectional analysis of the NEO study and the Indonesian National Health Survey study. So because we only selected those individuals aged 45 to 65 in the Indonesian National Health Survey, we can see here that the mean age were actually similar. And then we can see that both in the Indonesian population and the Dutch population, they both have slightly more women than men. The number of highly educated individuals in Indonesia were less than 10%, whereas it is more than 40% in the Dutch population. When we see at smoking as a risk factor, we can see here that Indonesian men has the highest proportion of smoker, namely 2/3 of them. And when we look here at the level of BMI and waist circumference, although here we can get an impression that the level of BMI and waist circumference were much higher in the Dutch population, this has to be interpreted carefully because of the different cutoffs that were used in Indonesia and the Netherlands. In fact, if we are to transform this level of biomarkers to the components of metabolic syndrome, we obtain this number of prevalence. So for example, here we see that the prevalence of abdominal obesity were actually pretty much similar in Indonesia and in the Netherlands, despite the different level of BMI and waist circumference. And also taking into account all other components of metabolic syndrome, we got a total prevalence of metabolic syndrome of 39% in Indonesia and also 29% in the Netherlands. And this is the result of our logistic regression analysis. So in this figure, we illustrate the association of overall and abdominal adiposity with the metabolic syndrome. So the left part of the figure is representing the overall adiposity with a standardized unit of BMI as the unit. And the right part of the figure is the result for the abdominal adiposity with a standardized unit of waist circumference as the unit. So we can see here, for example, well, anyway, this is the result for the Indonesian population first. I'll show you the result for the Dutch population later. So we can see here that, for example, per each increase in standard deviation of waist circumference, it is associated with more or less 2.3 times higher risk of metabolic syndrome in Indonesian men and in Indonesian women. So the blue line represents men and the red line represents women. And we can see here that the effect sizes was higher in the abdominal rather than in overall adiposity, showing that abdominal adiposity was more strongly related to metabolic syndrome than the overall obesity. And if you look at the component of metabolic syndrome, we can also see here that abdominal adiposity was slightly more strongly associated or similarly associated than overall obesity to the components of metabolic syndrome. And here is the result for the Dutch population. So the same pattern goes well for the Dutchman. So here we see that for each standard deviation increase of waist circumference, it is associated with around 2.9 higher risk of metabolic syndrome in Dutch men. But in the Dutch women, we saw the association to be the strongest. So for each standard deviation increase in waist circumference, it is associated with around 4.2 times higher risk of metabolic syndrome in Dutch women. And if we look at all other components, we can see that abdominal adiposity was also similarly associated or slightly more strongly associated to the components of metabolic syndrome, with an exception for hypertension being the only component, being the sole component that is more associated with overall adiposity rather than abdominal adiposity. So to summarize the key findings of my first study, well, we observed that abdominal adiposity was more strongly associated to the metabolic syndrome than overall adiposity for both population. And an exception existed for hypertension, being the primary components of metabolic syndrome that is primarily driven by overall adiposity or BMI. And also, although we first hypothesized that abdominal adiposity, which presumably represented a visceral fat associated to a different risk of metabolic syndrome in the two populations, well, unfortunately, we did not find evidence that abdominal adiposity was more strongly associated in the Indonesian population rather than the Dutch population.
Dr. Fatima,
and moving on to the result.
Sorry, Dr. Fatima, can I give you 2 more minutes?
Oh, 2 more minutes. Well, okay. Maybe I'll just go through the most important part of my study, my second study. So here we get that the level of leptin and adiponectin were lower in Indonesia than in the Netherlands, but actually, if we look at the BMI stratified population, we obtained that the leptin was more or less similarly associated in the same level, whereas the adiponectin was associated always consistently lower in the Dutch population, in the Indonesian population rather than in the Dutch population. And when we look at the association of leptin with the metabolic syndrome in the Indonesian population, we see no clear association between leptin and metabolic syndrome, whereas in the Dutch population, we see quite a positive association between leptin and metabolic syndrome. And when we look at the result for adiponectin, we see here that still, we also do not see a clear association between adiponectin and metabolic syndrome in the Indonesian population, but in the Dutch population, we see quite a negative association between adiponectin and metabolic syndrome and its component. So what I would like to summarize from the second study is, despite adiponectin was secreted in a lower level in Indonesia, it was not associated with the risk of metabolic in Indonesia. Therefore, it could not explain why does the Indonesian have an increased risk of metabolic syndrome than the Western. And we also did repeat the analysis in the BMI category, and we also did not find evidence that the association of leptin and adiponectin with the metabolic syndrome were stronger in the Asian Indonesian and the Western population. If I have to summarize my two studies into just one single sentence, well, it will be this. The differences in abdominal obesity as measured in waist circumference, and also the differences in serum leptin and adiponectin could not explain the increased cardiometabolic risk in the Asian Indonesian population. So other pathways rather than these associations should be explored to investigate why does the Asian population have an increased cardiometabolic risk. If I still have 30 seconds, Dr. Eric, well, this is my suggestion for future studies. We suggest future studies to use more direct measurement of visceral fat, because we only use waist circumference as our proxy for visceral fat. And actually, this is what we are going to do next. We are going to collaborate with the Singaporean Population Health Study because they have a direct measurement of visceral fat with MRI, and we will did the comparison study with the NEO study. And also because we only use metabolic syndrome as our outcome, we use future studies to investigate whether, for example, our exposure, such as leptin and adiponectin, still relates to these diseases, such as type 2 diabetes and cardiovascular diseases, via other pathways than metabolic syndrome. And also, we suggest future studies to use other biomarkers besides leptin and adiponectin to investigate the etiology of the increased cardiometabolic risk in the Asian population. And of course, our study probably should be better confirmed with GWAS and MR studies to observe the causality effect, the causal effect of the exposure to the outcome. I guess that's all that I would like to share today. And I also want to say thank you for your attention, and also to these lovely people listed in this slide, because without their help, our studies cannot be conducted. Dr. Eric, the floor is yours. Thank you.
Thank you very much. Thank you, Dr. Fatima, for your nice presentation. So I would like to invite all our three speakers, Dr. Joris, and then Dr. Kosaka and Dr. Fatima. All right. So again, everyone, thank you very much for your nice presentation. I see Joris here, and I think Fatima will be joining Dr. Kosaka already on the screen. So first of all, so this the title of this session is actually about big data analysis. All three of you already presented very nice research using big data. So one of the key message from all of your presentation is how we actually use all of these data, aka big data, to actually better improve our healthcare service, because that's what the people need. That's the question that, if I can put this perspective into Indonesian people perspective, that's what they need. right? So I think I haven't got any question on the chat columns, but if I can ask the first question to Joris. Joris, you present a very well presentations about metabolomics. You invented like 14 serum biomarkers who can predict mortality. So how your research actually helps your government or the policymaker in your country to actually use your findings in shaping their policy or the way the people should live in your country, Joyce?
Yeah, that's a very good question. So how we see it, so we are now at the first step, right? So we did it in epidemiological study. So the next step is, does it work in the clinic? If we can show that indeed it also works, which we have now indication that it's likely the case, then how we see it envision it to be used is that a person comes to the clinic, we measure these markers, and then we can say, okay, now we start a specific treatment for these individuals to improve it. And I think what's currently done is that there are not such good markers in the clinic. So people come to the clinic now, they measure their glucose, they say, oh, you have diabetes. They measure their cholesterol, they say, oh, you have cardiovascular disease. We think in the aging community that most of these things can be treated at once by treating aging. So the idea is somebody comes, we don't really know if this person is already diseased. It can even be before they are diseased, but we see that their profile is not good. So we can actually start the treatment before the occurrence of the disease. That's really the goal. And that's also, if that's successful, then it's very relevant for the general population, because what we can then prevent is that people come to the hospital and we are too late to treat them. We actually start treating them already before, and that prevents many things that are happening now, that we have many diseased people that are suffering, and that the cost for that in society are massive. So the idea would be, in our case, to identify people earlier so that we can treat them earlier. That's the main goal, to identify the vulnerable people.
Yeah, thank you, Joyce. Totally agree with you. Identify as early as possible. I mean, to prevent all the bad things that will happen to all of these people. And that was Dr. Kosaka show on his presentations. Dr. Kosaka, you are giving us a very nice presentation on how you built your national registry in order to help your own government to provide better care for patients with ST elevation myocardial infarction, as well as non-ST elevation myocardial infarctions. And this is also correlated with all this confounded diseases like acute kidney injuries. So I just would like to echo what George just mentioned. I mean, giving this research to the government, and you already did this, how you actually approach your government or the Ministry of Health or all these silver people up there on how you tackle things, on how you actually better provide a treatment for patients using your registry?
Sure. Two ways. One is sometimes the government actually asks you the question of how they did or how the policy change has really kind of like shuffled the medical practice, but that's rare. I mean, I get these like offers maybe like once every 4 years, 5 years, when things do match. The other way is we provide the data spontaneously or naturally, and then we go to the guidelines, recommendations, or professional societies, and then the professional society approaches the government. So that takes like 4 to 5 years. So it's a slow process, but it's better than nothing. You know, we can tell the government that, yeah, we're doing these things and we're watching. So the things are not that straightforward right now, but you know, hopefully small things at one time leads to like a bigger flow. So I think, you know, we see that thing happening in the United States and other countries. So I think it will be there. It will be here soon.
Yeah. Thank you very much, Dr. Kosaka. Dr. Fatima, there was a very nice research. I believe that's one of your research for your PhD. Dr. Fatima, how you actually use these findings to actually again, I'm going to echo the same question. How are you going to use your findings to actually help doctors or hospitals in Indonesia to manage these populations?
Okay, so thank you very much, Dr. Eric, for the question. I would like to say
before you continue answering the questions, I'm just going to be honest. Sometimes it's very hard to actually use those big data from Indonesia, especially from Riskesdas, right? So it's very interesting to see it on your presentation. So again, back to the question: how are you going to use your findings to better shape the healthcare?
Okay, thank you very much, Dr. Eric, for the question. And although my research is more etiological, so my aim, the general aim of my research is to look for the etiology of what is actually the etiology of the increased cardiometabolic risk of the Asian population. This can be some sort of like starting point to define the target therapy. So for example, I actually investigated, for example, whether leptin and adiponectin could be the responsible factor, could be the determining factor that may be the drive behind the increased cardiometabolic risk of the Asian population. Unfortunately, my result find negative findings, but that's all what science is, right? We have to still publish whether the result of our study is negative or positive. But actually, maybe the clinical findings, the clinical implication of my study is that maybe we can move on to other biomarkers of adipose tissue. For example, I've mentioned CD14 and EL18, whether they can be the next target to, like target therapy to prevent the increased cardiometabolic risk in the Asian population. And maybe because my studies find a negative result for leptin and adiponectin, then maybe we can keep our resources to study other biomarkers rather than these biomarkers. I guess that's all.
Thank you very much, Dr. Fatima. I know we are actually late for about 2 minutes. So there's okay, all right. So I'm just going to give one more question, and then I think if we can have another 5 minutes, I think I have one participant who would like to ask a question. But before that, to the three of you, how you act, because now in Indonesia, everyone is actually talking about big data. Everyone's talking about artificial intelligence. Whether this is going to be a hype or a hope, I'm quite sure. I'm not quite sure about it, but I'm very certain it's going to be a great hope for Indonesia if we actually use this data in a better way, or find someone who actually, or a group of people who actually have the same thought on how we actually do and manage this data in order to actually help the government to better shape the policy. But again, I'm just going to give the time to one of the participants, which is Dr. Farid Kurniawan. I think you would like to ask a question.
Thank you, Dr. Eric. I really enjoyed these sessions. Thank you, Dr. Dylan, Dr. Kosaka, and Dr. Fatima for giving very wonderful lecture. I will ask one question to all of you. Maybe you can give like short answer. The first one is to Dr. Dylan. Following up on the Dr. Eric questions regarding the intervention for and how to use your data for improving the healthcare. Do you know what are like the interventions in the clinical side that can be used or already advised to improve those metabolic risk markers that, like, because if I'm not mistaken, there's like several amino acids that being presently associated with a high risk of mortality, either intervention in the clinical that can.
Hello, Mr. Farid. I think we lost him. But again, Dr. Joris, did you get the questions?
Yeah. So actually, this is what we are trying to find out. Kind of what kind of interventions can work. We think many of these things can be dietary, actually, because many of the components that we are seeing in the score are dietary things that we can target. We don't know yet how good that will work. And of course, you have already some of these drugs available where we can look indeed, kind of if we take people that are already on these drugs, do they have a difference in their score? This is something that we want to figure out, what kind of interventions would work best, but we don't know yet. But based on what is in the score, definitely dietary interventions would already help quite a lot, probably, for many people.
All right. Thank you, Dr. Dylan. And my second question to Dr. Kosaka is regarding the National Registry of the Cardiovascular. I was wondering, what is the first step that when Japan have this National Registry for the Cardiovascular? Because I think Indonesia, we really want to have this big data of National Registry of certain diseases, are the cardiovascular type 2 diabetes. What do you suggest to set up first this National Registry, and what are actually the obstacles for this establishing of this National Registry? Thank you.
Hi. So we started off with the surgical procedures, actually, because the safety of cardiac and thoracic and other surgeries were kind of the focus of the Japanese patients over here, because the patients were not really sure whether their care was adequate or not. That became sort of a discussion after a few incidents of surgical miscarriage. And then the focus turned to the invasive procedures in internal medicine, because again, complication was an issue. The patient was really interested in safety of themselves. So after that came the sort of like the prediction, cost, and the other aspects of quality of care type. So the starting point was safety for the patient. So I think it will be a good start for most of the procedures that's acknowledged in all of the countries. So, and then we can focus more on the more detailed part. That's kind of my brief suggestions. But I'd like to talk about this more if there's more time. But I guess that's going to be the best take-home point.
All right, thank you, Dr. Kosaka and Dr. Farid. I think, Dr. Farid, you have one more question to Dr. Fatima, right? Or, hello? All right, I think we lost him again.
Hello? Yeah, thank you,
Oh,
Dr.
okay, he's
Kosaka.
still here, yeah.
And
all right, Dr. Farid, we keep losing you. All right. Anyway, I'm sure he will come back soon. But Dr. Kosaka, Dr. Joris, and Dr. Fatima, if I can get, because we can only extend the session in the next 2 minutes after 4:35. So next 2 minutes, if you can give a final statement, about what you have in common. You use big data analysis, right? And I'm sure one of the objectives, or primary objectives, is actually to, again, help the people in your country, the people in the regions, to provide better care, to provide something that can predict the disease as early as possible, right? If you can make one sentence, clear sentence for Indonesia, how Indonesia's best approach to actually manage all these non-communicable diseases by using big data. I'll give Dr. Fatima first.
Thank you very much, Dr. Eric. And maybe if you want the answer to be just one sentence, well, I guess big data is actually...
It will not be enough for one paragraph, though.
Well, big data is actually, it doesn't always have to be expensive. And actually, this can also still be started in Indonesia. We already have, like, for example, the Indonesian National Health Survey. We already have the cohort study for non-communicable diseases in Bogor. And also, we actually have the database of BPJS, or the Universal Healthcare from Indonesia. And that database, that big data set, actually can be accessed it is, if we request with a reasonable request, if we can prove to the data owner, the Ministry of Health, that we have a research question that is, maybe not groundbreaking, but do something for the health of the population, then it is actually a big opportunity, a big chance that they will give the access to us. So big data research should not be expensive, and it still can give us opportunity to answer many research questions.
All right, thank you very much, Dr. Fatima. Dr. Kosaka.
I'm going to say that the big data is a communication tool. The recommendation from the clinical practice guideline, it's one direction, like recommendation, that's it. But if you have the data, you have the tool to communicate with these guidelines or the government. So that's going to be my message.
Excellent. Dr. Joris.
Yeah, I would say indeed focus on affordable measurements that you can easily do, and try to make use of also the results that are already out there. I think we need to translate more. For example, we find a lot in European populations. We need to start translating it directly to other countries, to like Indonesia, see how it works, and then improve it based on what doesn't work, I would say. So first start with what's already known and try to improve it for the specific populations that you're working in, like the second presentation was showing, for example.
Yep. All right. Again, thank you very much, Dr. Joris, Dr. Kosaka, and Dr. Fatima. Thank you for your very nice presentation, and this is a very great discussion. I think I will keep you forever to discuss about the big data. But again, this is Sunday. I don't want to steal your time anymore. But again, thank you very much. It's very, very nice meeting you all. I'm hoping on behalf of the organizing committee, I would like to say again, thank you very much. And also in Indonesia, we now have a big data center at Indonesian Medical Education and Research Institute. So we would like to welcome you, Dr. Kosaka and Dr. Joris, to have more collaboration. And of course, Fatima is a family. So again, looking forward to collaborate more. Again, thank you very much for this session. Cheers.
All right, once again, thank you very much for the insightful presentation and discussion, Dr. Joris, Dr. Kosaka, Dr. Fatima, and also Dr. Eric. So, dear fellow participants, we finally reached the last agenda of today's event. We will begin the keynote lecture 3, titled Brown Adipose Tissue as the Major Target of Brain Metabolism, Diabetes, Cardiovascular Disease, the Current Evidence from Preclinical and Clinical Study. This session will be led by Dr. Diki Levinus Tapari as moderator. First, I would like to introduce you to Dr. Diki by reading his CV. Dr. Diki is from Metabolic, Cardiovascular, and Aging Cluster, Indonesian Medical Education and Research Institute. He is currently a chairman in Metabolic, Cardiovascular, and Aging Cluster, the Indonesian Medical Education and Research Institute, from 2021 until now. His staff division of Endocrinology, Metabolism, and Diabetes, Department of Internal Medicine, Faculty of Medicine, University of Indonesia. He is also chairman in the Indonesian Thyroid Association, Jakarta branch. He is also a treasury in the Indonesian Society of Endocrinology. So without further ado, please welcome Dr. Diki. Good afternoon, Dr. Diki.
Okay, good afternoon. Thank you for the very nice, very kind introductions, Dr. Mutiara. Okay, good afternoon for all the attendees. Also, maybe good morning for all those who reside in Europe. So we come to the last sessions of from the first CMARS. So it's quite interesting that the first session was open with the topic of brown adipose tissue, and then the last sessions that we would have today also about brown adipose tissue. So in this last session, the lecture on brown adipose tissue will be delivered by Professor Dr. Patrick Ransons. He is currently a professor in metabolic aspect of vascular disease, Department of Medicines, Division of Endocrinology, LUMC Leiden, the Netherlands. And he also a guest professor from the Department of Endocrinology, first affiliated hospital of the Xi'an Jiaotong University, Xi'an, China. So he finished all his degree from Leiden University, and he did a lot of studies concerning the association with adipose tissue and also cardiometabolic disease. So without further ado, I would like to invite Professor Ranson on the spotlight. Okay, good afternoon. Good morning.
Good morning or good afternoon,
Yeah.
Dr. Pari. Hi.
Okay, time is yours, Prof.
Thank you so much. Does it work showing my screen?
Yeah, clear.
Oh, super. Okay, I'd like to start off thanking you, but also Dr. Giuliano Barinda for inviting me to present this lecture on brown fat. And I'm quite glad that the first lecture from Professor Shimizu already introduced some concepts, so I can skip a few. Today, I'd like to present our data showing the role of brown adipose tissue as a target in cardiometabolic diseases. And I'd like to sort of combine the evidence we have from mouse models as well as from clinical studies. So just to, as a very quick reminder, brown adipose tissue is present in neonates. Between the shoulder blades is a bit of a brownish tissue. And whereas white adipose tissue functions to store fat and glucose as triglycerides in adipocytes, brown adipose tissue has a different appearance. It has multinocular, it has more lipid droplets per cell, and has a bit of a brownish appearance because there's a lot of mitochondria in the tissue. And in the mitochondria, as you know, I mean, nutrients are combusted by glycolysis and beta oxidation, and leads to electron-rich donors that provide electrons to the respiratory chain, and that leads to a proton gradient across the inner membrane of a mitochondrion. And in tissues such as heart and skeletal muscle, these protons are used to drive ATP synthase. So ATP is formed in skeletal muscle and heart, for example. But in brown adipose tissue, there is a specific protein that's called the uncoupling protein 1, and that sort of forms a pore within the inner membrane of the mitochondrion, and that leads to a dissipation of the proton gradient, and that results in the production of heat. So brown fat is the function of brown fat is to produce heat to keep the body warm, and heat is then delivered to the blood, and that can circulate the heat to get the whole body warm. So it was long thought that only neonates have brown fat, but it wasn't until approximately 2009 when we realized that also we as adults have brown fat. This is a PET CT scan where fluorodeoxyglucose is being injected into a person on a thermal neutral temperature. And then you see that the brain lights up because the brain uses a lot of glucose for energy. And also here the heart lights up. But when we cold expose a person for 2 hours until his shivering point, then you see a lot more FDG being taken up by spots that are not, that apparently are brown adipose tissue. So the brown adipose tissue in a human being are located above the claviculae, but also around the aorta and a bit around the kidneys. And apparently after cold exposure, it takes up quite a lot of glucose. This is how it works. So under a cold environment, TRP channels in the skin are being activated. That leads to a neuronal signal towards the hypothalamus, and that is translated into a sympathetic nerve system that releases noradrenaline in brown adipose tissue, and the noradrenaline binds to beta receptors, which are the beta-3 receptor in the mice, and it leads to intercellular activation and the influx of glucose within the brown adipocytes. What was very interesting is that in 2011, a group in Germany led by Professor Heeren showed that if hypertriglyceridemic mice were exposed to cold, already within a few hours, triglycerides disappear from the plasma. So brown adipose tissue doesn't only take up glucose, but apparently it also is able to clear triglycerides. And triglycerides in the circulation are contained by chylomicrons and VLDL. And this is just a reminder how they are involved in metabolism, according to textbooks until 2011. So chylomicrons are produced by the small intestine. They contain dietary lipids. The VLDL particles, they are produced by the liver, and they are also very triglyceride-rich lipids, but then they contain lipids that are derived from the liver. And these triglyceride-rich lipoproteins mainly serve to provide fatty acids towards heart muscle and white fat. And that is done by selective hydrolysis of the triglycerides by lipoprotein lipase, or LPL. So the LPL liberates fatty acids from triglycerides, and those are used for ATP production in heart and muscle, and they're used for storage in white adipose tissue. Then by lipolysis, the particles, especially VLDL, LDL is being produced. That's very cholesterol-rich lipoprotein that serves to deliver cholesterol to tissues that need it for membrane synthesis or steroid hormone synthesis, like the adrenals. But also cholesterol is a precursor for vitamin D. So we then decided to try to understand how brown fat deals with lipids, and for that we make use of triglyceride-rich lipoprotein-like particles. So these are recombinant lipoproteins that I developed when I was a PhD student a long time ago in 1995. And how we do that is basically we have commercially available lipids like triglycerides, cholesterol esters, and we combine them with phosphatidylcholine, lysophosphatidylcholine, and cholesterol in a reaction tube. We sonicate those lipids in a sort of buffer and then perform density gradient ultracentrifugation. So we get fractions of 45, 80, and 150 nanometer. So for most experiments, we have used particles of 80 nanometer. And during the sonication process, we can also incorporate radioactive lipids. And we incorporate glycerol trioleate as a triglyceride, but also cholesterol oleate. And the oleate is labeled by tritium. And with 14C, we can label cholesterol oleate. We can then inject those in the tail vein of mice. We use a lot of mice also in our research, and then look which particles or which organs take up the oleate or the cholesterol oleate. And then Geert de Hoeke, who was a PhD student in our lab, did a very simple experiment where she just injected these particles in mice at room temperature. And here you see that already at room temperature, a lot of fatty acids are taken up by the brown adipose tissue. And when we cold expose mice only a few hours at 7 degrees, you'll see that the uptake of the fatty acids is highly increased. At the same time, we also see some uptake of the cholesterol esters by the brown fat, but the uptake was about 10-fold lower. And the majority of the core label is taken up by the liver. So this is very compatible with a mechanism where brown fat, just like white fat and just like skeletal muscle, but also heart, selectively takes up fatty acids, and in brown fat that is then used for heat production and not for storage or ATP production. So this is the textbook as we know it now, where brown fat is an equal player in lipoprotein metabolism, just like white fat, muscle, and heart. So why is it important? Well, that's because we as humans are nowadays more and more in a positive energy balance, where we take up a lot of nutrients that are stored in white fat. So the white fat therefore expands, cells die, and that leads to insulin resistance of the white fats and lipid overflow of fatty acids that are then stored in the liver, leading to NAFLD and NASH, but also in the muscle and heart. And that results in an overproduction of lipoproteins by the liver and less uptake by the fatty acids by the heart and muscle. And that in turn leads to dyslipidemia, where LDL increases, where triglycerides increases, and where HDL cholesterol seems to decrease. And then the increase in mainly LDL cholesterol is that a driving force for the uptake of LDL in the intima of arteries, and it leads to atherosclerotic cardiovascular disease. So the idea that we, but also other groups have, that if we can activate brown adipose tissue, then that may reduce adiposity, it may reduce lipid accumulation in ectopic organs. And that is what indeed happens. Many groups, also the group of Professor Shimizu, has shown that we can, at least in mice, attenuate adiposity and attenuate the liver accumulation in the liver. So we thought that we may also see a reduction in dyslipidemia and atherosclerosis. And we did a lot of experiments, mainly using the ApoE3 Leiden C2P mouse. This is quite a specific mouse that we developed here in Leiden, in the Netherlands, that are hypercholesterolemic, hypertriglyceridemic, but they do respond to the lipid-lowering effects of drugs such as statins and PCSK9 inhibitors. And that is quite nice, because then we can combine those lipid-lowering strategies with experimental strategies and see if they can have additional value. Well, this slide basically summarizes a lot of studies that have been initially performed by Jimmy Berbet and later on also by other people in our group and in collaboration. And what seems to happen is that when we cold expose mice, or when we treat mice with a beta-3 receptor agonist, we activate thermogenic adipose tissue, and that leads to selective liberation of fatty acids from triglyceride-rich lipoproteins. And then remnants are formed that are very quickly taken up via the ApoE LDL receptor pathway by the liver. So that leads to a reduction in cholesterol in the plasma, and therefore also less influx of cholesterol in the plaque. So we see a lowering of atherosclerosis by this pathway. At the same time, when these particles are reduced in size, there is an excess of phospholipids that are fed into the HDL pool. So HDL has a higher capacity to take up cholesterol, for example, from foam cells in the plaque, and that leads to reverse cholesterol transport, because the liver is capable of taking up the cholesterol esters selectively from HDL. So that also helps in reducing atherosclerosis. So the cholesterol that is delivered to the liver is rapidly converted into bile acids, and those are secreted via the bile into the small intestine, where a part escapes enteropathic circulation and are secreted into the feces. And we have done quite some experiments to show that if we increase LDL receptor expression either by a statin or a PCSK9 inhibitor, then we can even enhance the anti-atherosclerotic effect of brown fat activation. We also realized later that brown fat is not only activated by cold or by beta receptor agonism, but also light has a very nice effect on brown fat activity. And that is because basically every energy process in the body has a diurnal rhythm that is synchronized by the daily light exposure. So every day in the morning, the light feeds onto the suprachiasmatic nucleus. That's the master biological clock in the brain, and via neuronal and also hormonal signals, then local clocks within the brown fat, liver, skeletal muscle, and white fat are synchronized. So in the brown fat, we do see, when we look at the glucose uptake by a micro PET-CT, that there is some diurnal rhythmicity in the uptake of glucose that is highest at the onset of the wakeful period in mice, which is a night period. And then we, of course, we also looked at the diurnal rhythmicity of the fatty acid uptake from lipoproteins. That's what has been done by Rosa van den Berg and Sander Kooijman in our lab, who showed that if we inject these particles with triglycerides labeled with a tritium label, that when we look at the white fats, there basically is not so much rhythm in the uptake of the fatty acids by the white fat. For the brown fat, there is a very high rhythm, with a very high uptake of the fatty acids just in the beginning of the wakeful phase. And when we make the light period longer, then also the peak uptake of fatty acids is still in the beginning of the wakeful phase that starts in the night period. So you wondered what would drive the diurnal rhythmicity of the brown fat activity. And what was very striking is that when you look in the blood at the corticosterone rhythm, that very nicely is in line with the fatty acid uptake rhythm by the brown fat. So what we postulated was that that maybe corticosterone would drive the uptake of the fatty acids by brown fat. So Maaike Schilpoort, another PhD student in our lab, performed then an experiment where she implanted subcutaneous pellets that either release nothing or release corticosterone at a very low dose. And we can use that to break the HPA axis and basically to flatten the corticosterone profile over the day. So in the control experiment where the pellets only released vehicle, we see a very high diurnal rhythmicity in corticosterone, also in the LPL protein in the brown fats, and that coincides with this same rhythm in fatty acid uptake by interscapular and subscapular brown fats, also by perivascular white fat that also behaves quite a lot like brown fat, also with very high fatty acid uptake. But then in the mice that contained a pellet that released corticosterone, we see that the rhythm is completely flattened of corticosterone, but also of the LPL protein in the brown fat, and the fatty acid uptake by the brown fat doesn't produce then a peak anymore, but is basically flat. And we think that's very interesting because we have looked at the corticosterone, the cortisol rhythm in patients or persons from South Asian origin, like people from India, and they have very much reduced corticosterone levels in the morning. And that coincided with lower uptake of glucose by brown fat, as we showed in 2014. So the idea is that the daily diet exposure synchronizes the suprachiasmatic nucleus to produce the corticosterone rhythm. We know that corticosterone is a regulator of angiopoietin-like 4, and this is an inhibitor of lipoprotein lipase. So that would then lead to a rhythm in LPL that is synchronized to the rhythm in corticosterone, and therefore a synchronized rhythm in the fatty acid uptake by the brown fat. Of course, we still had to prove that, and we did that later on in a more recent paper produced by Robin van Enige and Wietse Panhuis, also from our lab. What they did is that they did mRNA sequencing of brown fat that was collected every 3 hours in the day of mice. And then we were able to determine almost 14,000 genes, of which more than a third was rhythmic. So they were expressed in a rhythmic pattern. And we have basically could identify 4 clusters with different rhythmicity. And in the first cluster, the gene with the highest rhythmicity was indeed lipoprotein lipase. So the protein and the activity pattern is partly explained by already a rhythmicity and the LPL mRNA expression by the brown fat. And also interestingly, in the 4th cluster, there was indeed the angiopoietin-like 4 expression was had the highest rhythmicity of all genes in that cluster, basically of the whole data set, and that was anti-parallel to LPL. So as the expression of LPL is very high at the onset of the wakeful period, the expression of angiopoietin-like 4 is the lowest. And because angiopoietin-like 4 is an inhibitor of lipoprotein lipase, we set out to find out the causality here. So we did that by again injecting particles in the beginning and the end of the wakeful period in wild-type mice and also in angiopoietin-like 4 knockout mice that don't produce that protein. So the wild-type mice, we see the expected rhythmicity and LPL protein activity and fatty acid uptake by the brown fat. But if we do the same in angiopoietin-like 4 knockout mice, then at the time that normally LPL is inhibited, we have normal LPL protein expression. Also, the LPL activity in the brown fat is the same, and we have attenuation of the rhythmicity and fatty acid uptake by the brown fat. So that sort of shows that angiopoietin-like 4 is indeed a regulator of the diurnal rhythmicity and the fatty acid uptake by the brown fat. Well, this, of course, is mouse work, and we wanted to know whether humans also show a diurnal rhythmicity in brown fat activity. And therefore, Mike Staat cold-exposed young volunteers either in the morning from a thermoneutral temperature to a stable cold temperature where the participants just don't shiver. And she did the same also in the evening. So at 7 o'clock in the morning or 7 o'clock in the evening. And then she showed that when you cold expose, this was in men in the morning, that the time needed until shivering was longer. So apparently people are able to produce more heat in the morning. And that was indeed the case because the cold-induced energy expenditure in the morning was higher than in the evening. And also we look with a thermal camera to the regions where brown fat is located. We see a higher increase in the temperature in brown fat in the morning than in the evening, which is suggestive that we can activate brown fat better in the morning, in the evening. And we have the feeling that has to do with the cortisol being high in the morning. Of course, we could not really prove here that brown fat takes up more fatty acids in the morning, but it's still something we want to do later on. So then we started studies also to see if, because we showed in mice that lipoprotein metabolism and atherosclerosis can be improved by brown fat activation, and we wondered if that's also the case in humans. And Kimberly, Nahon, Huub van Eyck, Maaike, and Carlijn have done studies by cold exposure and also by pharmacological intervention to see if we can see similar effects in humans. This slide was already shown by Professor Shimizu, showing that when we retrospectively look at almost 140,000 PET-CT scans and look at persons who were positive for brown fat or negative for brown fat, then the people positive for brown fat have a lower prevalence of type 2 diabetes at every BMI tertile, also for coronary artery disease, and those persons have lower triglycerides and higher HDL. Which is all very aligned with the data we find in mice. So we tried to see if these associations could be causal, and we did that by cold exposure of young men and women. And Maaike Staat did that again by the same protocol between two cooling blankets, and she took plasma samples every 30 minutes until 2 hours. What she saw there that the fatty acid levels in the plasma increase in time, and that's logical because cold exposure via sympathetic activation leads to intracellular lipolysis in white fat, and it leads to an increase in the fatty acids in the plasma. When we look at the triglycerides, we don't see very much. We see a slight decrease after 30 minutes, but overall, we don't see a lot in the total triglycerides in the plasma. So we looked with lipidomics. We want to see what the different species would do of all the lipids that are in the blood. And here you see that in orange, we see an increase of many different fatty acid species in the blood. And for triglycerides, we see that over 120 minutes, quite a lot of triglycerides decrease, but also a few increase. And here you see that most of the shorter triglycerides decrease in time. And that is basically because we think that these fatty acids from triglycerides are taken up by thermogenic tissues like brown fat, maybe other tissues. And in the end, we see especially the longer triglycerides, they are increased in the plasma versus time 2.0. And so our hypothesis was that these fatty acids that are released are going to the liver, and they are used for triglyceride production that leads to particles that can feed onto thermogenic tissues. So we tried to see in mice if that was indeed true. So a very short-time cold exposure in mice also leads to an increase in triglyceride levels in plasma, and that could be completely inhibited when we pre-treated the mice with an inhibitor of intracellular lipolysis, which we call HGL-lystatin. So that's an inhibitor of the intracellular HGL molecule enzyme that is involved in the liberation of fatty acids. So yeah, based on that, on other studies, we could indeed conclude that cold exposure leads to sympathetic activation of a white fat to liberate fatty acids. Those are going to the liver, where sympathetic activation increases the production of triglyceride-rich lipoproteins like VLDL, and those are then used to feed onto thermogenic tissues like skeletal muscle and brown fat to deliver fatty acids. Again, we don't have as yet a PET scannable triglyceride tracer, so we have not been able so far to also prove this in humans to be true. So then, can we also activate brown fat in humans pharmacologically? And in 2015, there was quite a promising paper where Aaron Sipes showed that if we treat people with a single dose of myrbetriq, and this is a beta-3 receptor agonist that is used in the clinic to treat an hyperactive bladder, then we see an enormous increase in the uptake of FTG by brown fat. And that coincided with an increase in the resting metabolic rate. So that was good. And at the same time, the heart rate and also systolic blood pressure increased. That is not what you would expect with only activating brown fat. And therefore, we and others thought that there was a large activation also of beta-1 receptors on the heart at this dose. And you should realize that the dose that was used here was 4 times higher than the normal pharmacological dose that is used to treat a hyperactive bladder. So based on these experiments, we collaborated with Denis Blondin from Vancouver in Canada. And we did exactly the same experiment, but then with a dose of 50 milligram of myrbetriq, that is the pharmacological active dose. And there we did not see any activation of the brown fat. So basically, we had the idea that maybe the beta-3 receptor that is most prominently present in brown fat in mice and responsible for its activation is not the dominant receptor that activates brown fat in humans. And indeed, Eline Kuipers did some studies in brown adipocytes from humans. And basically, she stimulated these brown adipocytes with myrbetriq, with also formoterol, a beta-2 specific activator, and norepinephrine. That is the neurotransmitter that normally activates brown adipocytes. And she saw in all instances a high increase in the fatty acid release from the brown adipocytes. And it was completely blockable by a specific inhibitor of the beta-2 receptor, which may indicate that myrbetriq activates brown fat cells via the beta-2 receptor. Also, when we look at the liberation of glycerol from the brown adipocytes, we saw similar effects there, and also the effects of a beta-2, a beta-3 receptor agonist was inhibitable by a beta-2 blocker. Then also, when we take biopsies from humans, from the human brown fat, we saw that the beta-3 receptor was marginally present, and the main receptor in human brown adipose tissue is in fact the beta-2 receptor. So that led at that time at the conclusion that probably the beta-3 receptor is mainly used in mice for a neurogenic activation of the brown fat, and in human brown adipocytes, it will be mainly the beta-2. So more recently, we have treated humans with a beta-2 receptor agonist, which is salbutamol, also used in the treatment of asthma. And we did it in a randomized crossover design in young, healthy men. So what we did here, we injected salbutamol intravenously, and we just thereafter started the dynamic PET-CT with HNF fluorodeoxyglucose to look at the total uptake of glucose by the brown fats. So to estimate the effect on energy expenditure, we measured energy expenditure before treatment and also just after the treatment to look at the difference there. And we also pre-treated these participants with either placebo or with a beta-1/2 specific antagonist, which is propranolol, to see if we could block a potential increase in the uptake of FTG by the brown fat. And what we indeed saw is that salbutamol increased the uptake of glucose by the brown fat, which was much less in the presence of the propranolol. And when we look at all participants together, we do see a high, I must say, a high variability between persons. But on average, there was quite a high increase in the uptake of the FTG by the brown fat, not by skeletal muscle and not by subcutaneous fat. And this increased uptake of FTG by the brown fat was virtually completely blockable by propranolol. So then also the increase in energy expenditure was higher with people only getting salbutamol and compared to the people getting salbutamol and propranolol, and also the fat oxidation was higher. And when we looked whether we could see any correlation between changing in energy expenditure with heart rate differences, that was not the case. Also, the net glucose uptake by the skeletal muscle was even inversely related to the increase in energy expenditure. And we did see that the net glucose uptake by the brown fat had some positive correlation with the change in energy expenditure. And from these data that were just published 3 days ago, we could conclude that salbutamol apparently does not activate the beta-3 receptor. Still, via the beta-2 receptor, it activates brown fats to increase the glucose uptake, and that is related to an increase in energy uptake. The last few slides I want to spend on talking about a novel tracer that we are currently preparing, because so far most of the human experiments looking at brown fats look at the uptake of FTG by brown fats, and we find that a bit puzzling because FTG normally is largely taken up by the brain, and that needs a lot of glucose for energy delivery. We also know that the FTG uptake by brown fat is decreased in people who are who have more body weight or who are older. And we can explain that basically because people who are older or are more obese, they have insulin resistance. And from our mouse data, we already showed that glucose uptake by brown fat is largely decreased already 1 day after feeding a high-fat diet, which causes insulin resistance of the brown fat. Others have also shown that glucose uptake by the brown fat is mainly used for lipogenesis, not so much for direct combustion. And that's also what we see if we cold expose mice or humans, then the combustion of lipids is increased and not so much the combustion of glucose directly. Then Maaike Schulpoort did an experiment with a GPR 120 agonist, and that's also able to activate brown fat. There we see with deoxyglucose only a relatively small increase in the uptake by the brown fat, and we see a 10-fold higher uptake of triglyceride-derived fatty acids. So we reasoned that if we could make a triglyceride labeled with 18F that follows the fatty acid uptake of triglycerides, then the selectivity may be increased for the uptake of fatty acids by activated brown fat. Also the specificity and the selectivity, because we would not target the brain, and hopefully that would also lead to lower doses of 18F that we can use in the end to trace brown fat activity in humans. So this is what we have been currently doing, and we have just been able to successfully synthesize a triglyceride where the 18F is positioned on the second fatty acid of a triglyceride. And Xishon Ying has improved the methods of the particle preparation so that it's very short particle preparation time because, of course, the half-life of the 18F label is very short. And we have just been able to do that, as I mentioned, and we have compared that with FTG uptake by brown fat without and with activation of the beta-3 receptor in the mice. We do see that the uptake of FTG by the brown fat is a bit increased, as others have shown as well, when we treat with the beta-3 receptor agonist. But then also the heart lights up a lot, and there's quite a lot of uptake of FTG by the heart. When we do the same with the triglycerides incorporated in the triglyceride-rich lipoprotein particle, we see a much higher difference in the uptake of fatty acids by the brown fat. And here we can visualize the interscapular and the subscapular brown fat very nicely. And then the uptake by the heart is much reduced. We do see, of course, some uptake by the liver, because lipoprotein remnants that are still triglyceride containing, they are taken up by the brown fat, by the liver in long term. So in the end, we see that when we take out all the different tissues for a kinetic study, that brown fat already after 5 minutes after injection takes up a lot of the particle-derived fatty acids, and that increases very nicely in time, and we have quite a high selectivity for brown fat. So to sort of wrap up, the main messages is that we have shown that brown fat plays a role in metabolism of triglyceride-rich lipoproteins through LPL-mediated uptake of fatty acids in mice and probably also in humans, but we still need to develop this tracer for human purposes, hopefully in a few years, to really be able to conclusively mention this. We also show that the LPL activity in brown fat is highly rhythmic, and that involves transcriptional LPL regulation by piperid gamma. I haven't shown it today because of time reasons, but there's also post-transcriptional regulation of LPL by angiopoietin-like 4. And in research that we published also last year, we showed that rhythmicity in brown fat is largely lost upon aging in mice and probably also in humans. Brown fat activation attenuates dyslipidemia and atherosclerosis in mice, and brown fat that is active associates with lower prevalence of cardiovascular disease in humans. And yeah, we are quite convinced that while the beta-3 receptor mediates noradrenergic activation of mouse brown fat, the beta-2 is basically the receptor that activates brown fat in humans. And yeah, right now I think that the main challenge will be to see whether long-term activation long-term activation of brown fat by chronotherapy. We think that activation in the morning is more beneficial in the evening. To be done to look at the therapeutic effect of brown fat activation on lipoprotein metabolism and atherosclerotic cardiovascular disease. And such a study is now underway, because we got quite a good grant from the Heart Foundation in Holland together with the British Heart Foundation in England. So we can, together with researchers in England, look at long-term cold exposure of humans and see what our cardiometabolic outcomes will be. So if you would like to know more about the details about brown fat activation and the collaboration between the several organs, I'd like to refer you to a very nice review of Xichong Ying in cardiovascular research published last year. Yeah, I'm very grateful to the collaborators that we have thus far, both in the Netherlands, also in Copenhagen, Graz, Canada, Munich, and Sherbrooke, who collaborated on mainly the human parts of this research, and are mostly embedded to all the brown fat men and women, our bad men, bad women, who contributed a lot to all the research in the lab that I presented today. I'd like to thank you also for your kind attention. Thank you.
Okay, thank you very much, Professor Ranson. A very amazing lecture. So it is very interesting. While waiting for the question from the audience, is there any question from the audience? You can just raise your hand. Okay, I see Dr. Jeffy. Please, Dr. Jeffy.
Okay, thank you very much for your wonderful presentation. So yeah, I have two kind of questions. So the first question is, so it's logically that the people with who live in the extremely cold area, like the Arctic population, is more healthier because they're more has a brown adipose tissue activation. So my question is, have you ever analyzed some like brown adipose tissue activity or something related with the metabolic phenotype in those area, and then compare with some maybe tropical area like in Indonesia, yeah, something like that, and also maybe people who has a like an asthmatic patient who has who take salbutamol as their daily medicine. So I was wondering about the the brown adipose tissue activation. So yeah, maybe that's the first question, and I would like to continue to the second question later. Thank you.
Yeah. Thank you very much for the question. Yeah, of course, there's always a difficult question. I got this question a lot, whether people who are in different zones of the world would have more active brown fats, and if that would relate to a more beneficial cardiometabolic phenotype. I think, yeah, the problem is that we can never look at brown adipose tissue isolated from all the other things that we do in life. And we know that people who are in colder environments, also in Dutch winters, we have much more dense foods than in the summer, where we eat more salads, for example. So also when you look at the eating habits all over the world, those are different. So it is already very difficult to look at an isolated effect of brown fat activation over the populations in the world. The problem is also that only a few years ago, it's difficult to really look at brown fat activity and the metabolic activity of brown fat. We use this FTG PET scan, and that is basically quite an expensive method. So we're now looking for biomarkers for brown fat in the circulation, because if you would have them, you could more easily compare people from all over the world and look at their brown fat activity, if they are very selective, of course, for the brown fat. We have recently found one that we're still trying to replicate in different populations, but it's also something that is not easily done. What we do know, for example, with winter swimmers, people in Scandinavia who dip into ice cold water 2 times a week, that is what they like to do. They have more active brown fat, and on average, they have lower triglycerides in plasma. So there is some cardiometabolic benefit. Of course, I'm not really sure if also their general behavior is more healthy than the people who don't do these winter swimming activities. So yeah, I can't give you a very clear-cut answer there. At least for the beta-2 receptor, I think it's very interesting that there is quite a common polymorphism in the beta-2 receptor, and people can really be discriminated based on triglyceride levels, but also the adiposity, because the mutant, the lower frequent mutant within the beta-2 receptor is associated with higher lipids in plasma, higher cholesterol, higher triglycerides, and more body fat. And there are some anecdotal papers showing that people who use a beta-2 receptor agonist on average have a lower body weight. But of course, they are also, they use it for a certain purpose. So it's very hard to see if that is causally linked to the beta-2 receptor agonist.
Okay, thank you very much. So if it's possible, so my second question. So my previous lab was extensively studied about the adipose tissue angiogenesis, that the improvement of angiogenesis could convert the white adipose tissue into the brown adipose tissue and as an anti-obesity treatment. So my question is, what do you think about the role of the angiogenesis in the brown adipose tissue if we could somehow improve the angiogenesis process in white adipose tissue from obesity patient? Maybe it will be beneficial for them, or maybe not. Yeah, what do you think?
That's a very good question again. At least we know from quite a lot of studies that when brown adipose tissue, at least in the mouse, when it's getting less active because you feed the mice, for example, a diet high in fat, then you see less capillary structures within the brown fat. And the idea could be that maybe that is a sort of response trying to deliver less nutrients to the brown fat, so there is not more accumulation of nutrients in the already whitened brown fat. Alternatively, you can also, we know from enos agonists that is able to increase the capillaries, for example, the brown fat, and that is related to a higher uptake of glucose by brown fat. So yeah, given the fact that white adipocytes can transform into bright adipocytes, or they can be generated from the precursors that are in the white fat, it would at least be interesting to yes, if you can sort of induce vascularization, and in the end also to induce browning of white fat. I'm not completely sure, but I think it's an appealing concept. Yeah.
Thank you very much for your question and for your answer.
Okay, thank you, Dr. JP, Professor. Before to Dr. Farid, I have one question, Professor Ranson. You are using salbutamol to induce the beta-2 receptor. Have you ever thought about using, for example, thyroid hormone to induce the thermogenesis in the brown adipose tissue? Because we often saw our patients in the clinic with hyperthyroidism also increase thermogenesis. Also, it might also possible to induce the brown adipose tissue as well. What are your thoughts on that?
Yeah, that's a very, very interesting point. What I do sort of understand, there was quite a recent paper that I have somewhere here. Oh yeah, where I understand that, I mean, thyroid hormone has sort of different functions in different organs. So there was a paper published last year in the Nature Communications by another group that showed that basically you have to target thyroid hormone to white and brown fat to have the beneficial effects of thyroid hormone there without, again, the adverse effects elsewhere. What they very nicely showed in a mouse model is that if you incorporate thyroid hormone in a nanoparticle that you very selectively target to white and brown adipose tissue via a peptide that was discovered by phage display, then you could highly increase thermogenesis in a mouse that was related to a loss of body fat and other favorable properties. So what we're now basically here doing is try to get the salbutamol within a similar particle, because when I was a PhD student, I was a lot into drug targeting. So I have these liposomes that we can incorporate them in and selectively target these agonists specifically to brown fat to see if that's happening. I think that, yeah, there's something what you could do with thyroid hormone. It's something you can do with other activators like a beta-2 receptor agonist. But we haven't done it yet, but we are now currently trying to get these selective targeting concepts.
Okay, thank you, Professor Ranson. And in Indonesia, actually, it was also very interesting because we have also an area with quite hot during the all around the year. We also have an area also very cold all the year, for example, in the mountain area. But of course, it would be a bit difficult to dissect the exact mechanism because, of course, they usually climb more. When we did our research in Flores, we also observed similar. So among those who live in the beach area, they have a lot of more diabetes and obesity, while those who live in mountain area and colder area, they also less. But of course, there's also other factors as well. It would be interesting to study those as well. But the problem is actually how to assess the brown adipose tissue, because it's quite expensive, right? How to assess the brown adipose tissue.
Yeah, that's a major problem still. I mean, there are a lot of groups who want to try to see if you can use a thermal camera to look at the brown fat, and we do see that in short cold exposure experiments, we do see that the brown fat activation that we see, at least with the energy expenditure increase, is related quite well with the increase in the temperature in the supraclavicular area. So there is at least a correlation there, and this is also methods we are gonna pursue in the cool bed experiment that we're gonna do in the next months, where we cold expose persons in the morning and the evening for a long time, because that is a relatively cheap method. And yeah, we do collect the plasma, and we, as I said, we have now at least one sort of biomarker that seems quite specific, and we try to see if we can get additional biomarkers, not only from the lipidomic field, also metabolic fields. If we combine that we have more power to estimate the brown fat activity. Then again, is that an estimation of the glucose uptake, is an estimation of the fatty acid uptake, or an estimation of the actual heat production that is basically the function of the brown fat? So there are a lot of challenges still in this type of research, for the near future, I'm afraid.
Okay, thank you. So we will go to the last questions, short questions. Dr. Farid will get last on the schedule. Please, Dr. Farid.
Okay, thank you, Professor Renson, for very excellent lecture and very interesting data. My question is regarding the immunology. I think I haven't seen the data relating immunology because adipose tissue is really related with the immune system and inflammations. And do you have any data regarding this brown adipose tissue associated with the immune system, whether in mice or in human, and whether we can evaluate those marker in the immune system related with the brown adipose tissue in human? That's my questions. Thank you.
Yeah, thank you very much for the question. Yeah, we have certainly looked at the immune cell infiltration in the brown fat. For example, when you that was again in mice, where we put them on the thermoneutral temperature, where the brown fat is not active, you see an increase in markers of the so-called pro-inflammatory macrophages, like M1 type macrophages that are increasing in the brown fat, and that's very rapid. And we do see that that is also related to a lower insulin sensitivity of the brown fat, because we see the accumulation of macrophages just before the uptake of the glucose, where the brown fat is decreased. On the other hand, when you beneficially modify the brown fat, you see macrophages go down, and macrophages that are present are more M2 or anti-inflammatory like. I am not too sure if we can use that data, for example, to modulate brown fat specifically, because I think in general, I think if you have, anti-inflammatory therapies would be beneficial for complete metabolism, also elsewhere in the body, like in NASH, maybe in NAFLD, together with that also in the brown fat. I'm not really sure how we can very specifically improve the function of the brown fat, but we could maybe do that in the end with brown fat targeted concepts again. And also, currently, we're not looking at immune parameters as sort of proxies for brown fat in humans. That could be interesting later, but I'm a bit afraid that the number of cells you see in the brown fat are a very minor fraction of the cells we have in the body, so that in the end, maybe that is not doable, possibly.
Thank you, Professor Renson.
Thank you, Professor Renson. Unfortunately, because we are already late behind the schedule, I think there's still a lot of questions to be asked. I hope you don't mind if we can also send an email to you to ask several questions if you're allowed. Okay, once again, thank you very much, Professor Renson. It's a fantastic lecture as well as discussion as well. Hopefully, we can further collaborate as well on this aspect of brown adipose tissue. Okay, thank you very much, Professor Renson, and also for the attendees. We already come to the end of our last sessions, and now I would like to give the time back to Master of Ceremony, Dr. Mutiara. Please, Mutiara.
All right, thank you very much, Professor Renson and Dr. Diki, for the engaging session related to the brown adipose tissue. So, dear fellow participants, today is the last day of CMARS 2023. Before we end the session, we would like to hear the closing remarks from the chairperson of the first CMARS 2023. So please welcome Dr. Agian Javilano Barinda.
Okay, thank you very much, Dr. Mutiara as the Master of Ceremony. So I would like to show some brief data about the CMARS. So thank you very much. We had last session or the last. Oh, sorry. Okay, so this is the brief information about the CMARS. So regarding to the characteristic of the participants, oops, sorry. So can you hear me? Sorry.
Yes, it's audible. Yeah. Yes, we can hear your voice.
Okay. So I would like to thank to all the participants. So we have 216 participants, mostly from Indonesia, about 191 participants. But interestingly, we also have some overseas participants from Iraq, 1, Japan, 8, and Netherlands, 7, including the participant from the Professor Patrick Ransen's laboratory, and also from UK, Germany, and from India. Thank you very much for all the participants. And the characteristic of the participant is mostly the general practitioner or the researcher. And interestingly, we also have some participant that has some PhD, get the PhD, and also the specialist, and also the student or the undergraduate students. So again, thank you very much for all the speakers, for the wonderful speakers. Without you, maybe this symposium will become difficult without you. And also thank you very much for the organizer, Professor Badrul Hegar as the director of IMERI, Professor Budi Wiweko as the vice director of IMERI, Dr. Diki Tahapari as the head of MVA cluster, and also all of the organizer that I cannot say one by one here. Thank you very much for them. And most importantly, thank you very much for all the participants here that have joined from the beginning until the last session of this one. So again, we still have surely we have various limitation in our symposium. So please give your constructive feedback here, and we will be glad to hear your voice. Again, thank you very much, and see you at our next CMARS conference. Thank you very much.
All right, thank you very much, Dr. Agian, for your presentation. We will also like to invite Dr. Dikita Apari as the head of MVA in IMERI to give closing remarks before we end the session. So Dr. Diki, the time is yours, Doctor.
Okay, thank you, Mutiara. So I'm sorry, I think my internet connection is unstable currently. So yeah, I think what I want to say is actually would like to say thank you very much for all the honorable guests who were willing to share their expertise and their research in this conference. And of course, to also all the attendees who has actively participate on the discussions, sessions. And of course, for Dr. Jeffy as the head of the symposium, and who make all the things like possible. When we first discussed about this symposium, we saw it as like very giant work to do, but finally Dr. Jeffy could really do it quite well with his team, and hopefully we can run this similar program every 2 years, hopefully to be able to always share a recent advance in research in the aspect of cardiovascular, metabolic, and also aging research. And what we want to achieve by this symposium is actually not only sharing the expertise, but also to foster further collaborations between all the speakers as well as all the participants in the symposium. I think that's all for me. Once again, thank you very much for all your participation in this symposium. Thank you.
All right, thank you very much, Dr. Diki, for the closing remarks. So to all participants, we finally arrived at the end of the session of the first International Conference of Cardiovascular, Metabolic, and Aging Research Symposium. We hope this conference will leave a good impression on all the guests and also on our fellow participants. As a reminder, all the participants could fill out the attendance form that we provide in the chat box, along with a feedback form for this webinar. Your feedback will help us to improve the symposium for the better. Please kindly fill out the form directly afterwards. This event would not be successful without our sponsors, Novartis, Novo Nordisk, Prodia, AstraZeneca, and Vidya Genomic. Thank you to all sponsors and media partners. And as an appreciation to all participants, I would like to invite all of the participants, speakers, and committee to turn on your camera to take a group photo together. So please turn on your camera to take a group photo. I will wait for 1 minute. All right, so for the documentation team, please help to capture the photo. Okay, let's take the photo. There's several slides here, so we will take the photo in 3, 2, 1. All right, second slides. 3, 2, 1. Amazing. Wonderful. Okay. Thank you very much. On behalf of the organizing committee of CMARS 2023, I would like to offer our gratitude to all participants and guests for your enthusiasm during this conference. Until next time, and see you at the next event.